Uh, Good evening, everyone. So once again, we would like to welcome all the participants who have been participating from a very long time with us from the time this lockdown has started. So today we're going to have two important topics, which we may not come across that frequently, but this is something which we need to know as a neonatologist. So the two topics are fetal and neonatal hydronephrosis approach and acute renal failure. So today we have two wonderful presenters who are young and dynamic and who are quite famous for their presentation and making things very simple and easy by taking a lot of references. It looks like they make us feel very simple and easy. So we have with us Dr. PRASHANTH Y N. He is assistant professor of Department of Neonatology at prestigious St. John's Medical College. And followed by his talk, we have Dr. ANKUR RAJVANSHI. He is a chief consultant neonatologist at Cloud9 Hospital, Whitefield, Brookfield. Thank you very much for accepting our request. So now I request Dr. Prashanth to start the session. We will take up all the questions and queries. I kindly request to post it in the chat, or you can personally send the question. Or once the session is done, both the sessions are done, personally you can unmute and you can ask one by one. You can raise your hands and unmute, ask one by one. So now I request Dr. Prashanth to start the session. Over to you, Dr. Prashanth.
Thank you, sir. Thank you very much for that introduction. I hope I keep up to your expectations. A very good evening, everyone. I'm Dr. Prashanth. I work as assistant professor at St. John's Medical College in the Department of Neonatology. At the outset, I would like to thank our NNF Karnataka for giving me this opportunity to interact with you in this forum. I personally would want to congratulate Dr. Prashant Gowda and Dinakar sir, who have been taken this tremendous efforts to keep this wonderful thing, which is going for almost like, I think it's reaching 100 sessions now. Yeah. So coming to my topic per se, so my topic is fetal and neonatal hydronephrosis and approach. So I'm going to talk about approach more practically. So this is my overview. So I will take you through the definition and probably the etiology of hydronephrosis, and how do we grade fetal and neonatal hydronephrosis, and how to probably plan an approach to a case of hydronephrosis, both antenatally detected as well as postnatally detected. So let's start with the name game, an icebreaker, right? So all of us would have heard many nomenclatures here. So some say pilectasis, some say hydronephrosis. So both interchange to define the dilatation of renal pelvis with or without dilatation of renal calyces. So, but usage-wise, both seem to be the same. And there is also an other entity or other nomenclature called pelvictasia. We'll talk about it in the subsequent slides. So, but to get to a neutral position, not to make it pathologic or probably physiologic, a new terminology probably which has been popularized after 2013 is SERP, that is sonographically evident renal pelvis. So, which actually takes a neutral position. And there's another terminology called hydrouretronephrosis. So where your dilatation of renal calyces or the pelvis is associated with dilation of your ureters also. So when you look into the incidence of this hydronephrosis, as we all know that the incidence is more in case of males when compared to females, is as much as twice as that of females, and bilateral cases make up to 20 to 40% of the cases, and it is the incidence varies from different studies from 0.6 to 4.5% of pregnancies. Contrary to what Prashant sir said, so it is actually one of the common things which you would see. Suppose you are having a delivery of 100 babies in your unit, probably you're going to see anywhere between 1 to 5 babies who have some or the other ultrasound problems, so which points towards hydronephrosis. At St. John's, our incidence, though I think I should say that it's an underestimate from NNPD data of last year. So our incidence of pelvic ectasia was around 0.8% of live births per month. So the incidence is not very low, is what I'm trying to say. So let's get into the flashback before we go to the actual algorithmic approach. So flashback means I'm taking you to your UG days of anatomy classes. So just a brief review of gross anatomy of your kidney, which you need to know to understand different um, uh, um, uh, uh, different definitions or different explanations. So you will see here. So you have renal columns. You will have renal capsules here, which makes a part of renal capsule, which actually covers the kidney. And you have this renal pyramids, and you have this base of renal pyramid. The important for us is our renal cortex. Other things are the calyces. You have minor calyx and major calyces, and you have renal pelvis, which actually opens to the ureter. So this is a typical gross anatomical explanation of your kidney. So we all know the embryology. This is from Inderbir Singh. So all of us are familiar with this. So we know I'm not going to go into the depths of development of kidney. So what I want you to know is, you have a ureteric bud, which is formed from the mesonephric duct, where it attaches to the metanephros to form kidneys. And finally, it forms the well-formed kidney. So you have you have a tube which actually goes and get merged with your urogenital sinus. So ultimately forming the urinary bladder here. This is the embryology in brief. So why is this important is because during development there could be some of the physiological factors which probably will lead to this hydronephrosis. So when you look into the etiology, we have two types of hydronephrosis. One is transient hydronephrosis. So transient hydronephrosis means it's a transient narrowing of the uteropelvic junctions early in the development that resolves as the fetus matures. So this is transient because it resolves on its own. So why does it happen? Because the metanephric urine production appears as early as 8 weeks of gestational age. So this happens potentially before the completion of your ureteral canalization. So some amount of urine is blocked there, and also during the development of the ureter, there could be some angulation in the ureter, which could possibly lead to uh, uh, dilatation of the renal pelvis. And another big entity called the congenital anomalies of the kidney and urinary tract, which also causes the dilatation of the renal pelvis. So we're not going to talk about this Acute group. So, but we're going to talk about, instead, we're going to talk about the transient hydronephrosis. So when you look into the differentials of antenatal hydronephrosis, if you look at these numbers, the transient hydronephrosis accounts to almost 88% of the cases. Suppose you have 100 cases who are diagnosed with hydronephrosis. Majority of them, around 90% of them, will have transient. So that is probably a normal variation of development which is happening, and rest of it could be a pathologic phenomena. For example, pelvic-ureteric junction obstruction, vesico-ureteric reflex, vesico-ureteric junction obstruction, megaureter, multicystic dysplasia kidney, duplex kidneys, etc. So we're not going to talk about all the other Acute group. So I'm going to concentrate on transient hydronephrosis, which we see in most of the cases. And of course, this probably is our domain because the babies will be born with us. So we will have to do antenatal counseling, so probably postnatal counseling, and also have follow-up with them from medical point of view. So to look at hydronephrosis, we need to grade them. So what amount of dilatation is pathologic? For us to know, we need to grade it. All of us know about all of us know about this first grading. It's called renal pelvic diameter, which we have been taught over years. And there are new classification systems which have emerged of late. One is Society of Fetal Urology Criteria, another recently urinary tract dilatation classification system. So let's look at each one of it in a little bit of detail. So renal pelvic diameter basically is the maximum anterior-posterior diameter of the renal pelvis. If you can see the cross section here, so it's a maximum diameter of the anterior-posterior of your renal pelvis. The dark part represents the pelvis. The brown is the kidney. So this is a cross section of a kidney, and this is the most generally accepted method. And this actually is a uh, ultrasound picture of the cross sections where you can see both a right and left kidneys in cross section and the pelvis. So based on the renal pelvic diameter, so the hydronephrosis have been graded as mild, moderate, and severe. So when we look at second trimester, from 4 to 7 millimeter comprises mild, 7 to 10 millimeter of renal pelvic diameter will be named as moderate, and if it's anything more than 10, so it is said to be having severe hydronephrosis. So in the third trimester, the cutoffs increase. So 7 to less than 9 is mild, moderate is anywhere between 9 to 15, and more than 15 millimeter in your anterior posterior diameter of your renal pelvis is considered as severe hydronephrosis. So just to in brief, so in second trimester more than 0.5, we classify the hydronephrosis as pelvicectasia between 4 to 10, and more than 10 is associated with CAC, so which is pathologic, right? In third, anything more
Kindly unmute, Prashant.
so this is the classification according to the renal pelvic diameter trimester wise. So when you look at this, so second trimester and third trimester is a large time frame, right? So this graph represents the risk of postnatal postnatal urological uh, urologic pathological abnormality based on the renal pelvic diameter related to the gestational age. So for example, so this has on x-axis you will see the gestational age, on the y-axis onto your right you will see the percentage in normal, on the left side you will see the percentage of uropathy. As you see, the percentage of uropathy is inverse to this. So suppose for example, if a baby you see a anterior posterior diameter of the renal pelvis being around 10. So I'm gonna mark it here. It's a 20 weeker, so I'm gonna mark it here. So at this point of time, the percentage of normal outcome of this baby is probably 60%. But whereas if you look at the uropathy, it's exactly opposite. So probably 40% the baby might have uropathy later on. So another example of baby who is 32 weeks having a pelvic diameter of around 6 millimeter. So let us look at this. So it will go here. So 70% of the time the baby probably will be normal, and 30% chances are there the baby can be uropathic. So this actually gives a gestational age based cutoff. So probably good way to predict what's going to happen to the babies later on. This is based on anterior posterior diameter of the renal pelvis. So so we talked about the different grades here. So the grades actually started to come into existence based on the requirement of surgery with certain cutoffs. But we all know with every cutoff for any investigation, so we are dealing with so sensitivity versus false positive ratio. So if you if you were to increase the cutoffs to a higher value, so probably your sensitivity would increase, but actually your false positivity also would increase. But if you decrease if you decrease it, so it'll be vice versa. So when to start off with, so when Dr. Cotwell et al. Looked at this, so they said more than 4 millimeter before 33 weeks and more than 7 millimeter after 33 weeks would predict a requirement of surgery in the newborns. However, it has been contested. These cutoffs have been contested in various other studies of late. So, example for this, study which was looked at which looked at anterior posterior diameter and requirement of surgery. So 35% of patients with APD less than these values still required extensive postnatal urological care. The other on the other hand, uh, uh, this particular study which looked at the cutoffs, so which had higher cutoffs, said 100% sensitivity of detecting urological abnormalities. So we have both the things which have to be balanced, and we probably don't know the exact cutoff till now. So when when we talk about the renal pelvic dilatation, we are not looking at anything other than kidney, and we know that excretory system consists of the functioning kidney, which includes the other calyxes, renal pyramids, renal cortex, and it also could involve your bladder. It also will involve the problems with the ureter. So looking at all this, so Society of Fetal Urology came up with a grading system, so which was a little bit more detailed when compared to renal pelvic diameter. So SFU grade 1 involved urine barely splitting the renal pelvis. As you can see, this is the cross section of a kidney, and you can see only a split here. So the renal pelvis is probably not enlarged. So when you look at SFU grade 2, SFU grade 2, so the pelvis is full. Pelvis will appear full, and the major calyces will be dilated. SFU3 would consist of uniformly dilated minor calyces, and the parenchyma is paired. So red consists of the parenchyma, blue consists of the area of the pelvis. Sorry. So SFU grade 4 comprises of parenchymal compromise. So the dilatation happens so much that the parenchyma probably has compromise. So this has looked into not only the renal pelvis, it also has looked into the calyces, how the calyces are, and also has looked at renal parenchymal problems. So another classification system, so which was proposed in 2014 by a multidisciplinary consensus on the classification of this hydronephrosis. They looked at anterior posterior diameter of the renal pelvis. They looked at calyceal dilatation. So all these things were included. So the renal parenchymal thickness and renal parenchymal appearance also was taken into account. So they also took into account the bladder abnormalities, and they also took into account the ureteral abnormalities. So this might look little complicated, but if you can see from the renal pelvic diameter, so this classification system is probably looking very comprehensively at the excretory system. So based on this, so they classified it into A1, A2, A3 in case of postnatal presentation. So, but in prenatal presentation, so A stands for antenatal. So A1 consists of low risk. So when in between 16 to 27 weeks, your AP renal pelvic diameter is 4 to 7 millimeter, and there are no calyceal dilatation. So probably the baby is having low risk of some uropathy later on. So this happens. This holds good for any dilatation between 7 to 10 millimeter after 28 weeks. So, but if the pelvic diameter has increased and there is peripheral calyceal dilatation, if there are parenchymal thickness abnormalities, appearance which is abnormal, ureters which are abnormal, bladder abnormality. So all these would constitute as increased risk. So increased risk means to say probably these fetuses probably will have more chances of uropathy or chances of requirement of surgery postnatally. So in the same stratification holds good for the postnatal postnatally also. So this is classified as P1, P2, and P3. P1 remains the same, that is low risk, but the second is differentiated into P2 and P3. P2 comprises of intermediate risk. So where your pelvic diameter is more than 15 millimeter with peripheral calyceal dilatation or ureters which have got involved. So it actually constitutes constitutes of intermediate risk, and if all other things which are involved along with the increased renal pelvic diameter constitutes a high risk. So these are the three classification systems which are being used. So this actually gives an overview of UTD risk stratification in case of postnatal presentation. So NL stands for normal appearance, P1 is mild abnormality, P2 is moderate, and P3 is severe abnormality. So all these things are based on ultrasound findings of the fetal kidneys, fetal or. So how does it matter to us?
Prashant, kindly unmute.
So the postnatal pathology increase as the degree of antenatal hydronephrosis increase. So as you can see, a mild degree of hydronephrosis will have very less chances of postnatal pathology. Mild will have approximately 12% of babies who have postnatal pathology. Moderate will have around 45, and severe also. Severe hydronephrosis will have around 90% of babies having postnatal pathology, and the numbers are little varied across different studies. So this depends on the type of classification system that they have used. So in this particular study, they have included SFU classification system, where you can see that as the degree of hydronephrosis increases, so the surgical intervention required also would actually increase. So that's why it's important for us to grade these fetuses in utero to predict the possibility of surgical interventions later on. So various studies have looked at combining these classification systems. So this is one of the retrospective studies which included around 350 babies. So they looked at APD versus SFU versus combined. They showed that using a combined definition for grading of the hydroureteronephrosis, the sensitivity increased. So this combined was approximately equal to the SFU alone. So probably this means to say that we need to move from just looking at anteroposterior diameter of the pelvis to probably SFU and probably a UTD system. So apart from looking at only the kidney for hydronephrosis, so as we looked at the differential diagnosis, I know this is a very crowded slide, so this is for the fellows and probably postgraduates. So this will give this table gives the ultrasound findings in utero in the fetus, which probably has pathologic hydronephrosis, and the subsequent recommended postnatal confirmatory tests. As you see, so all the differentials which I just mentioned. So the ultrasound findings are given, and also the subsequent confirmatory test also has been mentioned in this. So for this, so we also need to have additional features. So in the ultrasounds, and we need to define them apart from all this increasing in the diameters. So when we say it is when it is progressing, so we talk about more than 4 millimeter increase per month in the pelvic diameter. So we talk about fetal sagittal bladder length also. So when we talk about dilated bladder, so we are talking about a bladder which is 2 millimeter plus the gestational age in weeks of the baby. When we talk about mega cysts, so we talk about gestational age in weeks plus 22 millimeter. So these are the values. So when we say the renal length is elongated, so we are talking about the gestational age in weeks plus 5 millimeter. And we talk about hydronephrosis, so this is the definition. So more than 4 millimeter in the anterior posterior diameter with or without calyceal dilatation will actually comprises of hydronephrosis. And the other most important thing, which is closely associated with the kidney function is amniotic fluid index. We all know that the amniotic fluid is principally maintained by the fetal urine production, which begins at 16 weeks. And all of us should be aware of the cutoffs of the amniotic fluid index. So it's ideal to use gestational age-based graphs or a blanket definition of polyhydramnios or oligohydramnios based on STP values or AFI values need to be known. So to more so oligohydramnios to look at renal functions because it's closely associated with it. So additional features other than looking at only the excretory part is also the systemic abnormalities, because we know that most of the kidney renal anomalies will be associated with systemic abnormalities. So that's why the major systemic structural anomalies screening is actually very important. And we also should be aware of the soft signs in the ultrasonogram, fetal ultrasonogram, so which actually puts the fetus at high risk of abnormality. So I'm actually not going into the depths of each one of it because of want of time. So I'm sure that this will be put up in the recorded version. So I might share the PDF. I mean, so my PPT as well with you all. So looking into the approach of fetal hydronephrosis, so there's been so many consensus, so many guidelines, including Indian. So we have different for Canadian, we have different for American and for the UK. So I'll be taking you through the antenatal approach to antenatal hydronephrosis, which is given the clinics and clinics of perinatology. So this was published in 2014. But having said that, so this the overview or the broad principles remain the same. So probably it might be modified according to the region or the unit preference. So looking at the second trimester, if there is bilateral or suspicion bilateral hydronephrosis or there is suspicion of bladder outlet obstruction, so if the amniotic fluid levels are normal, all it requires is serial ultrasound scans every 2 to 4 weeks. If this is associated with oligohydramnios, then we are in trouble. So we need to look at whether it is a favorable outcome or an unfavorable outcome. Favorable outcome includes a favorable urine parameters, which I'll talk about in the subsequent slides, with no chromosomal or structural abnormalities. Unfavorable includes unfavorable urine parameters or any chromosomal or structural abnormalities. So if it is a favorable if it's a favorable parameters, so if you're looking at, so we probably would consider fetal intervention. If it's unfavorable, some centers would look for elective termination and some centers would look at expected management. So if you are looking at unilateral, so if it is, we classify it as severe if it is more than 10 millimeter. So the ultrasound need to be repeated every 2 to 4 weeks. If it's between 7 to 10, the ultrasound need to be repeated every 2 to 6 weeks. And if it is mild, so that is between 4 to 7, the repeat ultrasound can only be done in the third trimester. So this is the detection of this is for detection of antenatal hydronephrosis in the second trimester. So if a pregnant mother is detected in the third trimester to have the fetus to have this antenatal hydronephrosis, if it is bilateral or suspicious of bladder outlet obstruction, if it is normal amniotic fluid levels, so we need to repeat the ultrasounds every 2 to 4 weeks, and it also requires a postnatal imaging and treatment as indicated by the pathology. So if it is associated with oligohydramnios, again we are in probably trouble. Some centers would look for early delivery. Some centers would look for expected management. So this is based on the consensus of different units. So if it's were to be unilateral, severe would comprise of anything more than 15 millimeter of the anterior posterior diameter. So all it requires is a repeat prenatal ultrasound in 2 to 4 weeks, and the expected management would ensue. And for mild to moderate, which is defined by 7 to 15 millimeter, expectant management is recommended. And so all of them would require postnatal ultrasounds. So with this, so we actually talked about fetal intervention in the second trimester. So let's talk about a little bit on this fetal interventions. So first of all, it is controversial. So whether it really helps the babies or not, we probably don't know yet. So, but it could be considered in the mid second trimester fetuses with suspected bladder outlet obstruction with oligohydramnios and preserved renal function. So the most common intervention which has been described is vesicoamniotic shunt. So which theoretically is expected to improve the fetal renal and lung development. But however, different studies have shown only modest benefit in the pulmonary outcomes, and it's very much associated with complications. When I talk about preserved renal function, so this is for the fellows. So this table actually gives parameters for favorable outcomes. So we look at urinary sodium, calcium, osmolarity, total protein, and beta 2 microglobulin. So if all of these probably is in the normal range, so we would say that fetal kidney is functioning okay. So one of those ambitious study which took place looking at whether this percutaneous vesicoamniotic shunting would help in this fetal lower urinary tract obstruction, Pluto trial, so which was published in Lancet. So they had planned 150 enrolled pregnancy. However, the trial had to stop for only 30 enrollments. So since it was an intention to treat analysis, so they looked at the interim analysis also in this. So where they found beneficial effect of shunting on the survival. However, if you look at very closely into this study, so there was the RCT was not strictly enforced because there was so many crossover between the two groups, experimental group versus the other group. So this results need to be looked at very cautiously. So although these authors say that there might be some benefits, so after the publication, so all we have got is probably looking into the fallacies of this trial. So probably a baby in the mid trimester with the probable with an indication, so probably in a setting where they could do fetal intervention. So probably I'm not aware of any Indian center which would do this. So if they would do so, probably it should be with consultation of parents looking at the pros and cons. So with this, let's move on to the postnatal course. So what if a baby is a fetus who is having hydronephrosis now transits to postnatal course. So as we all know, the most important thing, so which we need to see is the physical examination before any of the lab investigation, because it will give us most of the clues. We need to be looking at single umbilical artery, which might say that the incidence of CACUT might be high in this baby, particularly the vesicoureteral reflex. We look at portophasis, which points to oligohydramnios, probably secondary to renal dysfunction. So looking at ear abnormalities or posterior preauricular attacks. So looking at the abdomen for prune bellies. So a palpable bladder probably, distended palpable bladder probably would point towards bladder outlet obstruction. And a palpable renal mass probably could be a multicystic dysplastic kidney. And a baby who probably has a meningoencephalous seal can have neurogenic bladder and also have hydronephrosis based on that. So these are some of the clues which actually tells us that these babies could have some problems in the kidneys, pathological problems. So for that, we need to go for postnatal imaging studies. So renal and bladder ultrasound is a standard of examination which we need to do. So the grading is similar to the antenatal evaluation. The same parameters would be followed postnatally also. So the timing, we all know that the babies will have physiological oliguria in the initial 48 to 72 hours. So probably so it's ideal to defer doing a postnatal ultrasound scan till at least third day. But if a baby has bilateral hydronephrosis or hydronephrotic solitary kidney. So we need to expedite getting a renal and bladder ultrasound scan done, ideally less than 24 hours. Another imaging modality which we need to be aware of is voiding cystourethrogram. So the indication being, if there is persistent postnatal hydronephrosis, the hydronephrosis has come to the newborn, I mean, is existing in the newborn now, with a renal pelvic diameter of more than 10 millimeter or SFU grades of 3 to 4, or babies who are having high risk of urinary tract infection, or if you are suspecting obstruction, so voiding cystourethrogram needs to be done. The standard timings is around 4 to 6 weeks, so we need to defer VCUG till then. But in case of infravesical obstruction, that is bladder outlet obstruction, it has to be done between 24, in less than 72 hours of life. So we know that probably this voiding cystourethrogram will diagnose different pathologies like PUV, VUR, megaureter, ureteroceles, MCQAD, as well as renal duplication. So there are also some criteria which actually says, so these are the criteria which we can look at where we can safely omit voiding cystourethrogram, so that if the APD is less than 7 millimeter, SFU grade of less than 2, APD less than 10 with lack of calicial involvement less than 10 on both fetal and postnatal ultrasounds, or 2 successive postnatal ultrasounds being normal. So these are the criteria where you can safely exclude VCUG, although we know that the utility is more in identifying different CACOPs. So this is I thought this is of a little bit of importance when you're talking about antenatal hydronephrosis, because vesicoureteral reflex behaves little differently when associated with antenatal hydronephrosis versus diagnosed after a febrile UTI. So this the incidence varies between 7 to 35% of patients with antenatal with residual antenatal hydronephrosis. So how is it different from the normal view? I mean, the pediatric view, or what we see, which is diagnosed after a febrile UTI. It is more prevalent in male neonates. It usually, when we detect it, it's of a higher grade, and it has high rates of renal parenchymal injury and high rates of spontaneous resolution as well. So the probably you might falsely panic because the VUR is of high grade, but it has got good spontaneous resolutions as well. So VUR in the setting of antenatal hydronephrosis, it increases the risk of UTI, especially in girls, in uncircumcised boys and neonates where we suspect obstruction. So that's why diagnosing vesicoureteral reflex in a case of antenatal hydronephrosis is important for us. So another imaging modality is diuretic renal scintigraphy. So here it involves a renal scan and administration of a diuretic. Typically we use furosemide in this. Agent of choice is technetium mag3. So it actually measures the drainage time of the renal pelvis, and it also assesses the relative contribution of each kidney to overall renal function. So it looks at the excretory part, that is the drainage of urine, also looks at the renal function as well. So usually it is recommended to do DRS at around 6 to 8 weeks of life. So what are the indications of renal scan, diuretic renal scan? So when there is moderate to unilateral hydronephrosis without VUR, so severe antenatal hydronephrosis regardless of postnatal ultrasound result, again without VUR, moderate or severe postnatal hydronephrosis, or any hydronephrosis where we anticipate bladder or urethral abnormalities, or we have persistent dilated ureter, or we have decreased amniotic fluid for no reason, but the baby is not having VUR. So these are the indications of doing a diuretic renal scan. So this is how the report looks. So what we get is the split differential function, which actually is measured by the relative uptake of the radionucleotides. As you can see here, the left renal left kidney, there seems to be a collection of this, but the drainage seems to be low here, and it also gives the drainage curve. So where you see the different curves, so this is normal. So where the drainage in the ureter is good, and if there is progressive blockade, this curves this drainage curve will plateau off. So the more the plateau means to say, the more is the obstruction in the ureter. So these are the two things which we look at in DRS. So split differential function, so which looks at the function of the kidney and the drainage curve. So with all this in mind, so how do we approach a postnatal hydronephrosis? So when we have already evidence of antenatal hydronephrosis, but the baby has suspicion of blotted outlet obstruction, so there should be an immediate ultrasound scan done. So there should not be any room for delay in this. And probably this baby should be subjected to micturating cystourethrogram. So otherwise, the postnatal ultrasound scan usually will be done after 48 hours. So if we find the SFU grades of 3 to 4 or SFU grade of 2 with the risk factors for UTI, which I will talk to in the subsequent slides, so we need to subject the babies to vesico micturating cystourethrogram. So after getting this scan done, if it is not qualifying for these two, so we need to do a repeat ultrasound scan at 1 month. If there is resolution, that means say we have 2 negative ultrasound scan. So we need to educate the parents for risk for UTI, UTI prevention and voiding hygiene. So if that turns out to be SFU grade 1, serial ultrasounds have to be done every 3 to 6 months until resolution. SFU grade 3, serial ultrasound again every 3 to 6 months to look for resolution. If the SFU grade is 3 to 4, then DRS is warranted. So in DRS, we will be able to make out whether the baby will require serial ultrasound or the baby should be subjected to surgery. So immediately this will be based on the pathology we are dealing with. So this just gives you an overview of postnatal approach to a postnatal hydronephrosis. This again is taken from clinics in perinatology. So why are we so much concerned about this hydronephrosis? One is because this dilatation per se or the urine accumulation can cause problems in the kidney function. And other thing is the UTI. So we all know about the incidence of urinary tract infection in hydronephrosis. So there's definitely evidence of higher incidence of UTI than in the general population. So historically, the risk factors have been SFU of grade 2 or higher, female patients, uncircumcised males in the first year, low ureteral dilatation, that is any cause which causes ureter to dilate will have increased chances of urinary tract infection. So the answer to this is continuous antibiotic prophylaxis, although we know that this is controversial. So more and more evidence are actually coming out to look at channelizing this continuous antibiotic prophylaxis. So this is one of those studies which had looked into the different factors in hydronephrosis which would lead to urinary tract infection. So as you can see, the female patients, so presence of obstruction is moderate to severe hydronephrosis, involvement of ureter seal were actually had higher incidence of urinary tract infections. So, this particular meta-analysis published in pediatrics looked at whether continuous antibiotic prophylaxis would help, but they found that the continuous antibiotic prophylaxis versus no antibiotic prophylaxis did not make any difference. If you can see the RR, it is so odds ratio here, so it is 1.73, but the confidence interval is 1.05 to 2.85, and it is touching 1. So probably it is not very much helpful. So when they looked at antibiotic prophylaxis in high grade hydronephrosis, it definitely helped in decreasing the urinary tract infection. So after this, there's a systemic review which has come in 2017. Although it was not a meta-analysis, they looked at what are the factors which were which your antibiotic prophylaxis will make a difference. So they saw continuous antibiotic prophylaxis versus no no prophylaxis, male versus female, it actually did not make any difference. But what favored antibiotic prophylaxis was a was a high incidence of UTI in case of uncircumcised male babies. So in case of high grade hydronephrosis, since there was increased incidence of UTI, this favored antibiotic prophylaxis. And so in case of hydroureteronephrosis, that is involvement of the dilatation of ureter, it made a difference. So just blanket adding of antibiotic prophylaxis for all hydronephrosis, or thinking that probably the one gender is more predisposed to other, probably will not make any difference. So this is the antibiotic prophylaxis protocol guidelines, which is given by the ISPN, Society of Pediatric Nephrology. So which was published before these two systemic reviews and meta-analysis had come. So they have recommended that postnatal antibiotic prophylaxis for all babies who have postnatally confirmed moderate or severe hydronephrosis, that is renal anteroposterior diameter of more than 10 millimeter, or SFU grade 3 to 4. So that is moderate to severe. So in case of a dilated ureter, so while awaiting evaluation, so all patients who have been detected to have vesicoureteral reflux, so we need to continue for 1 year. So the choice of antibiotics is, for the first 3 months, it's sulflexin 10 to 15 mg per kg per day. And then after 3 months, it could be changed to cotrimoxazole or nitrofurantoin. So when do this baby requires surgery? So when there is on our diuretic renal scan, the obstructive washout curve will plateau off, and if the differential function is less than 40%, or if the differential function is decreasing to more than 10% with serial scans, so that means the renal the kidneys are compromising, it might require interventions then and there. Or if there is any progression of hydronephrosis in the serial ultrasound scans. Other indications where surgical interventions are required is presence of pain, palpable renal lump, and recurrent febrile UTIs. So with all this, so we looked at antenatally how to approach in first trimester and second trimester, and probably an outline of how to approach a postnatal hydronephrosis. So combining the antibiotic prophylaxis and the surgical interventions, so ISPN has actually given a brief guideline. So probably this is what most of the units would prefer to follow. So I'm actually putting it for you guys. So postnatal ultrasound, so initial scan will be done in the first week as usual, and we'll repeat at 4 to 6 weeks, no matter what it is. And based on that, we classify them as no hydronephrosis, mild or moderate. If it is no hydronephrosis, no intervention, so probably we need to counseling for preventing of UTIs. So if it is mild hydronephrosis, as we said already, so ultrasound every 3 to 6 months until resolution. So if it is moderate to severe hydronephrosis, we need to do vesicurating cystourethrogram. If there is no vesicoureteral reflex, so then we need to subject this babies for diuretic scans. If it is not obstructed, so then probably we will have to repeat ultrasounds every 3 to 6 months until resolution. If in DRS it's showing obstructed, then surgery will be indicated in these cases. If there is vesicoureteral reflex, so continuous antibiotic prophylaxis has to be initiated. And if there are any features suggestive of lower urinary tract obstruction on maturating cystourethrogram, so the surgery reference needs to be taken ASAP. So this one is, so these are the guidelines and approach in nutshell regarding the postnatal hydronephrosis. So combining all this, so when we look at when we follow up a baby from antenatal, postnatal, and probably later on in the OPD, so probably this is what we need to be keeping in mind. So when the baby is still not born, so we need to stratify whether it is whether the baby is having low, intermediate, or high risk. and then we need to decide once the baby is born, so whether the baby will require prophylactic antibiotics or different imaging studies. And then based on the results, we need to have a plan about scheduling the different imaging modalities as we just discussed. So I would suggest each one of us have this kind of picture in mind when we go and counsel an antenatal mother with hydronephrosis, and probably this will act as a template for us to see which way the baby is going, and probably will also help the baby to keep in track. So as we know, the management, probably we won't be independent, or we can't be self-sufficient in managing these babies as neonatologists. So it should require a coordinated efforts from OGCs, ourselves, radiologists, pediatric surgeons, and pediatricians. So, and the other most important thing is the involvement of parents, because most of the times when they come up with abnormal ultrasound scans of postnatally or antenatally, they will have to be told about the natural progression of these problems, and probably if there are any concerns which have to these things have to be evaluated for a good outcome of the baby. So I'm just going to go through one video on parental counseling, if it's okay with Prashant sir. It will take 10 minutes, sir. So this I thought is a very good video on how to go about counseling antenatally. So this is from a US based platform called Computer Enhanced Visual Learning Module. So where it is intended to educate or train the healthcare professional, especially the fellows, and it also has a lot of parental FAQs and all, so which actually acts as educational material for parents. So is it okay, sir, to start this video for 10 minutes?
Play the video after the second talk.
Sure, sir. Okay, that could be done.
Okay, we'll play the video after the second talk.
Sure. So because I actually this video link is through the Clinics of Perinatology link. So it is not opening in any other independent links. That's why I thought I will show it here. So this I will be shown at the end of AKI talk. To summarize, so as neonatologists, we need to aware of the natural progress of hydronephrosis and its postnatal implications, and we need to keep abreast with the evolving evidence. So especially the grading and management, as we all know that nothing is foolproof, and the local protocol. So probably as I was saying, so some of the surgeons or some of the radiologists won't be very familiar with SFU gradings or UTD grading. So where we'll have to come to a common protocol based on the understanding by the radiologists and the pediatric surgeons. And the most other important thing is to keep parents involved through the management process, which ideally should start antenatally. Thank you.
Thank you, Dr. Prashant. Wonderful session. Already I've received around 10 questions. So we will take up those questions once the second topic is done. Sure. So thank you very much. Wonderful presentation. And most of the questions which have come up, most of the things you have covered briefly. So probably they need to know little in detail. That's sure. It. So we will move on to the next session. So I request Dr. Ankur RAJVANSHI. You can stop sharing.
Sure.
Dr. Ankur?
Yes, sir, I'm audible?
Yeah. Speak a little louder and you
yes,
can
sir.
Start sharing the slides.
Yes, sir.
Yeah.
Hi, good evening, everybody.
Yeah. Dr. Ankur is the Chief Consultant Neonatologist and Pediatrician at Cloud9 Hospital, Bangalore, Brookfield. Thank you very much for accepting our request to be a speaker for today's talk. So he'll be talking on acute renal failure, acute kidney injury. So it's a very interesting topic, and at times, in most of the places, when there is a resource limit is there, and when we don't have a specialist access, it is very important to know the basic things to handle acute renal failure, because most of the time it will be transient, and we can actually treat. If you're able to handle acute renal failure well, we will be able to pull out the babies. So it's a very important topic. So Dr. Ankur, over to you. Kindly introduce briefly about yourself, and then you start the session.
Thanks a lot, Prashant Gowda sir. My name is Dr. Ankur. I'm working as a consultant neonatologist and pediatrician at Whitefield Cloud9 Hospitals, Bangalore. And I'm highly obliged to the whole NNF Karnataka team for giving me this opportunity today on talking to such an important topic, which is quite important, quite relevant, and quite relevant to know for the management, and very common, though we sometimes say it's not so common, but it's a part and parcel of most of the diseases for which the baby comes to the ICU. Highly obliged to the NNF Karnataka team for that. Thanks to Dinkar sir, Prashant sir, Kishore sir, Kotrush sir for giving this opportunity. I'll start my talk. So these are the two institutes where I learned the neonatology, and it was a key in my life. Indira Gandhi Institute of Child Health and Manipal Hospitals, Bangalore, where I learned how to go ahead about neonatology. So as I start my talk, the most important thing I want to tell is that, in fact, the defining AKI, so much debate is still happening on the defining of acute kidney injury. To start with, it was an acute renal failure and ultimately turned into an acute kidney injury in 2004. So the journey of the evolution of the definition of AKI is so interesting, because there is no foolproof definition of AKI, especially in the neonatal population, and it's always been a research topic to find it as much as possible to do more towards the definition itself. The advent happened, it started somewhere in the Greece, Roman times, and you can see over a period of time till 2004 was the first time when a consensus came on the definition of AKI, which I will talk to you later. Before talking on the AKI definition, just wanted to go into the renal development and physiology and important relevance for the neonatology population. So development of kidneys is very important. It starts at 5 to 6 weeks of age and happens till 34 to 36 weeks of age. So that's why it is important to know about the prematurity and other things what the babies will have in those type of cases. Nephrogenesis, as I told, most active happens in the third trimester, and most of the nephrons in the kidney are formed in the third trimester. So third trimester remains an important thing for the development of the kidney and for the absolute working of the kidney over a period of time. The variation in the range.
Ankur, kindly unmute.
Hello. So
yeah, we can hear. Go ahead.
So most active nephrogenesis happen in the third trimester, and it ranges from 6,17,000 to 1.4 million. Most important is that we can see up to 2.7 million, 3 million of nephrons in the kidneys, and it's a very variable thing. We cannot say that this kidney will be having this much. Renal blood flow remains an important part in the renal development and physiology. The renal blood flow in the adult ranges about 18 to 20%, around 20 to 25% of the cardiac output. But it starts with 2.5 to 4% at birth, which changes to 4.5 to 6% at 6 hours of life, and ultimately becomes 15 to 18% at 6 weeks of life. So you can see the renal blood flow is such an progressive thing. So defining the AKI again becomes difficult here, because you don't know that how to define an AKI when the parameters are changing so fast. GFR, I will talk to in terms of GFR, the most important indicator, the glomerular filtration rate, about how it changes, how it varies from the population, from the neonatal population in the premature group, in the near-term group, in the term group, and how it keeps on increasing up to 2 years of age. Tubular maturity is again an important phenomena, and these are the foundations that tubular maturity is not so much in the initial life, and tubular maturity happens. So again, saying the just having the parameters renal indices on the and defining the cause cannot be appropriate because we don't have a tubular maturity at of an adult level. This is changes in GFR with advancing age. I have taken it from a recent paper. So very beautifully, we can see that in 29 to 34 weeks, we start at somewhere around 15 ml per minute per 1.73 meter square of GFR, which changes up to 50 to 55 at the time of birth. And it progressively increases, and up to 2 years of age, you can see that it reaches somewhere what the adult GFR is. So that's how it happens. That's how it's an important finding. So I will like to go ahead on postnatal nephrogenesis, and because the nephrogenesis is a constant phenomena, so I just wanted to talk on the nephrogenesis once the baby is born, and it seems to continue after the preterm birth, but the window of nephrogenesis may be shortened and abnormal. The most important thing I want to say is that it was very difficult in the studies to find it out whether how much is the nephron number and how the nephrogenesis happens once the babies are born in different gestational age group. It is more of a autopsy studies which give us the idea if it is done that how much is the nephron number and how it behaves once the baby is born. And there is a study from Australia which showed that acceleration and maturation of the kidney do happens once the babies are born premature, and but they have a small nephrogenic zone, which will ultimately have some effect on the kidney functioning and leading to AKI and other things, because it's small nephrogenic zone. And another is from the University of Miami, which demonstrated that glomerulogenesis happens till 40 days of life once the baby is born, and in infants weighing less than 1,000 grams. So, but it also showed, the Miami study also showed, meanwhile, that the babies with having, it goes up to 40 days, but again, the layers of the glomeruli are less, and the numbers are not so much as it's found in the adult population. So there are various factors which affect the nephron number during in utero, when the baby is inside, and when the early neonatal development. So I just wanted to highlight that more of the slide for fellows and PGs. Caloric restriction, protein restriction, iron deficiency, vitamin A deficiency, vitamin D deficiency, and different types of exposure to drugs, either post the baby is born or in utero, plays a pivotal role in the causes of decreasing the nephron number, and ultimately will have a decreased GFR and ultimately leading to AKI or CKD. So that's how it is interconnected. This was the first definition, which was defining acute kidney injury. It was an honor for all of the nephrologists and the neonatologists all across the world to define it. And it was published in the Clinics of Perinatology in 2014, though the conference regarding that, it happened in 2012. And it defined that AKI is classically defined as a sudden decline in kidney function resulting in derangements of fluid balance, electrolytes, and waste products. Most important thing, as I told you, this is definition pertaining to neonatal group, and it was really important that it came in 2014 as a paper. 2004 was a turning point in the definition of acute kidney injury in all the age groups, adult, pediatric, and everywhere. We are the first time the defining, quantifying, and classifying acute renal failure, and we came to a classification which is very well known as rifle classification. The rifle classification has gone through a tremendous changes, and it has been validated through numerous studies. And it started in 2002 when ADQI, Acute Dialysis Quality Initiative Networks, did a huge conference and found out, established the criteria of rifle classification of AKI in all the age groups, and it took another 3 years to reach a classification which was pertaining to the pediatric group, and it was called as P-rifle classification. It was done, the paper published was by the Akin, and they published in 2007 something called as P rifle. What I want to say, the rifle took two main things under consideration. The most important thing is serum creatinine values and urine output values. So we can see rifle criteria as it says: risk, injury, failure, limitation, and end-stage renal disease, loss of kidney function L. So the baseline, it is the 1.5 times of the base creatinine values or 2 times of the base creatinine values, and that's how it is being defined, and the urine output. So if we pertain to the P rifle group, less than 0.5 ml per kg per hour for 8 hours, less than 0.5 ml per kg per hour for 16 hours, or less than 0.3 ml per kg per hour for 24 hours, or complete anuria for 12 hours. This was the classification to define the different stages of the AKI. The neonatal rifle group was more or less same for the creatinine, and slightly changed for the urine output group. But a lot of, again, the studies were done, and it was in 2000. In fact, this is a one paper from in critical care where it told in 2009, after the definition of definition by the Acute Kidney Injury Network gave the definition of P rifle. It says that lot of work is still needs to be done in order to define the AKI, and we cannot be sitting over that. So then comes the KDIGO classification, which is considered as the standard of classification in the current scenarios. And this KDIGO classification was again classified. It classified the stages of classified neonatal acute kidney injury into 3 types: stage 1, stage 2, and stage 3. Where it says that again the rise from 1.5 to 1.9 times of baseline creatinine value, or any creatinine value increasing more than 0.3 mg per deciliter stat, or going from 2 to 2.9 times of the baseline value, or the third was the 3 times of the baseline value, or initiation of a RRT or serum creatinine value. Anything more than 4 mg per deciliter was definitely considered as serum as AKI stage 3, which is has a worst prognosis and worst outcomes. And urine output was nearly the same, 0.5 and 0.5 and 0.3, or anuria for 12 hours. But I tell you, because a lot of we know, as we have gone through renal physiology, it was very difficult to say or comment on the urine output. So update on the acute kidney injury in the neonate came by the Zeton Kezai in 2014 only, and where the definition of KIDGO was again modified, and it was just limited to the creatinine values as a standard, because it was very difficult to comment on the urine output. Many of us knows that most of the babies goes into non-oliguric renal failure, and they have non-oliguric kidney injury, and it is very difficult to ascertain urine output in the premature babies because of the tubular insufficiency. So it just came down to creatinine values, and it was nearly the same which we have discussed. Further, many studies have been done. Many factors have been found. Etiologies have been ascertained, and many studies have taken either this definition, where the creatinine value is only considered, or some have taken the creatinine values as well as the urine output along with it. So both the things were considered and taken in different definitions of this. But the modified KIDGO is till now, various research has been done, and till now is the best thing which we are getting, and is the best result. So I just took one paper from the AKI definition is evolving still, which I just told you, and they told that why we it is still evolving, what are the research gaps and opportunities, and what are the various work needs to be done, because serum creatinine in the neonatal AKI definition, serum creatinine. So if we talk about the serum creatinine, I will talk in detail what are the various limiting factors for the serum creatinine for validation in the AKI definition. And the most important thing, whenever we talk about the multiples of the baseline serum creatinine value. The point comes which baseline we have to consider, because we know that the maternal creatinine values are reflected in the baby's 3 to 4 days of life, and it becomes very difficult to define the creatinine values that it is pertaining to baby or the mother. It is of mother only, and taking the value or the multiples of that baseline, is it true, is it correct approach or not? So that remains an important factor. In fact, serum creatinine values again changes with varying gestation and postnatal ages, different age, sex, gender. So how to just take over it. Then use of urine output as criteria for defining AKI in newborn infants. So I have already told research is definite needed for urine output AKI in neonatal AKI studies, including comparison of serum AKI definitions and outcomes. And urine output is needed to define volume load. So as we all know that why we are so much worried about the urine output, because what is the, if the baby is having volume overload leading to ultimately oliguria, so what volume load or what is the change in the volume status you will take in these babies rather than just talking about the urine output. And there was a research gap, and in the last where you can see that the serum biomarkers or the different biomarkers have to be studied in order to find out what we are dealing with, rather than just sitting on creatinine and urine output values. So I will discuss urinary biomarkers or kidney biomarkers which help us to define AKI. But I will like to go ahead as definition. I'll just go on incidence of AKI. So incidence of AKI, frankly speaking, there is no any study which says that the incidence of AKI in the neonatal age group or the babies admitted in the NICU is so much. It is very much on the risk stratification, the population which is prone to have problems. It is different studies have taken different AKI definition guidelines and estimated the incidence. Recently, one study done by Awaken group, where our Dr. Sanjay Wazir was also one of the publisher. Is working in Cloud9 Hospitals, Gurgaon. So there, the Awaken study is one of the largest study done in order to find out the epidemiological causes of AKI, where they first told that the overall incidence of AKI in their study was around 30%. 30% for all the population or all the age group. So here I will take the AKI incidence preterm 18%, preterm extremely low birth weight 12.5%, sick near term 18%. Asphyxiated newborn, asphyxia is one of the leading cause of the neonatal AKI, and most of them, I tell you, if it is properly managed, it is just acute kidney injury which is completely reversible, and we see a good outcome in most of the cases. Sepsis remains again an important factor, and cardiac surgeries, a lot of work is done on the post cardiac surgeries baby going into AKI, and the incidence is quite high. It is around 62%. This is the Awaken cohort I've just put. It is, the slide is not so clear, I feel. It is a very messed up slide. So the most important thing I just wanted to tell on this slide is that various factors were taken into consideration, and what they have found is that I will discuss those things in detail, but gender, ethnic groups, race, and what is the site of delivery, whether it was an inborn or whether it was an outborn. In outborn, whether it was delivered at home, it was delivered in facility, it was delivered in PHC, or what type of facility it was. What was the Abgars at the time of birth, and different factors like prematurity, respiratory problems, baby on ventilator, sepsis, HI, seizures. These all things were taken into consideration in order to establish the causes of neonatal AKI, and all of them has been found to be statistically significant, and all of them play a important role in the development of AKI. So this is a very interesting study. It was again done in area of North India, where the neonatal acute kidney injury, a survey of perception and management strategies amongst pediatricians and neonatologists was done. Because there is no clear-cut definition guidelines only. There is not clear-cut. Most of the people don't know what is there to define that the babies have landed into AKI, as we have for other things like RDS or HI staging and other things. We don't have it. So huge difference was seen in, it was a perception taken from the practitioners, and a huge difference was seen in their assessment about AKI in different age groups, in different population, in neonatal population. So a lot of disparity from the actual incidence was noted. So this is not the incidence of anything, of any disease per se, but it was a perception of the different people, where we say that in preterm population asphyxia, cardiac surgery we have seen. And you will be surprised to see that if you have seen in cardiac surgery, they say that the incidence of AKI will be less than 20. But what we have seen in the studies, it is somewhere around 63 to 65%. So that's the difference, because so a lot of confusion, lot of consensus issues are there on just defining AKI and how to go ahead with AKI. So this was, I thought, well, we finish off the biomarkers because incidents we just noted. So urinary output biomarkers has been a debatable study, and lot of work has been done in order to just find it out what can be the different biomarkers, and if we can do it, we can find out what will be the different early diagnosis of AKI, or we can prognosticate the AKI. So different biomarkers have been done.
Ankur, kindly unmute.
Hello, sir. Yeah. So I tell you personally that most of us are not doing any of these biomarkers in our day-to-day practice. Most of us are studies still don't know that what is the feasibility and what is the accuracy of these biomarkers in the different population and for prognosticating, for knowing the early onset of the AKI. So it is still a very difficult, and cost is again an important factor whether we can go ahead with all the population or we cannot do it. So I just wanted to show that how the cellular phases of AKI are there, the clinical and cellular phases of AKI. So it starts as initiation where we start getting the decrease in GFR, and it is the first stage is ischemia. Ischemia can be because of the various causes. The most of the important causes of ischemia is pre-renal causes. We have pre-renal causes in ischemia where the volume depletion is an important factor. So ultimately, which lead to cell injury and GBM loss, and then exfoliation and tubular obstruction, or ultimately, if this ischemia is continued, ultimately lead to the tubular integrity failure. So this is first stage. Then it goes into extension where corticomedullary junction hypoxia happens, microvascular injury happens with obstruction, coagulation, and inflammation. And then we comes into the stage of maintenance where we start ultimately don't progress the disease, and we are in the phase that we are recovering. This is the phase where 4 to 7 days of life, and ultimately we recover or come out of the AKI in 10 days. Later, I will tell you that most of the babies who come out of the AKI in 10 days, we define it as AKI, or ultimately they land up in CKD, where the management is different, and it's a different ball game altogether. So recovery ultimately happens with redifferentiation and repolarization. So as I told you, so normal kidney function, increased risk of kidney injury, kidney damage, decreased GFR, kidney failure, and death is the sequence of the events if the AKI doesn't ultimately is intervened or doesn't go back to the normal stage. So this is how it ultimately happen: kidney damage, ultimately leading to GFR, ultimately leading to kidney failure, ultimately leading to death. So these are the different biomarkers at different stages which can really help us, like serum NGAL or urine NGAL or cystatin C or creatinine or urea. But I tell you, these were the different studies done by the different people in the different age group, different population of age group, and the causes like perinatal asphyxia, cardiac surgery, and where they found that what are the different probability of different biomarkers to be present. It's a huge slide. We can go ahead. We can see it later. The most important thing what we have come across is that the cystatin C, neutrophil gelatinase associated lipocalin, and interleukin 18, and kidney molecule 1, KIM1. And these are some of the biomarkers which has definitely shown that there is definitely some efficacy, and these are really beneficial in order to find it out whether we have the how to prognosticate the AKI. The other most important thing, the other most important marker was angiotensinogen, in urinary angiotensinogen in the presence of renin, which says that if you are finding that in the urine, then it is a very poor prognostic factor. And if you find that, then you are heading towards CKD somewhere or the other. So establishing the etiological causes, the most important now, what is the etiology of AKI? What are the different, we have seen now, until now you all have got the idea that what we are talking about, what will be the different risk groups for the AKI. But again, to discuss in detail, risk stratification is very, very important. We have to stratify the risk. We know there are some populations which are more prone to have these problems, and we should be more vigilant on those populations for AKI. The most important thing which I want to say, the traditional approach of AKI as per the pre-renal, renal, and post-renal is really unhelpful because the babies don't behave in that criteria, and most of the times we find overlapping causes, and it is not good to go ahead with this. And what happens most problematic in this classification is that unnecessarily most of the times you will say that the cause is pre-renal and you will load the baby with the fluid, which ultimately we don't want, and that is important finding. So pre-renal, renal is not so much used. For classifying AKI, it may be more beneficial to distinguish between conditions that reduce glomerular function, conditions that result in injury of tubules or glomeruli, and conditions that do both. So it is very good to, if we talk about what are the conditions that reduce glomerular function, like the glomerulogenesis, if we are talking about the premature babies, the injury of the tubules or glomeruli, like in the cases of HI, where the damage or the ischemia happens. So these it will be better if we classify in these terms rather than going as pre-renal, renal, and post-renal. Term and preterm population again poses as a very good, as you already we have seen here. So they have term units have somewhere around the congenital amnesia of the kidneys and urinary tract. Post-surgical complications, hypothermia, obstructive uropathies, and systemic metabolic derangements are more common in the terms population as compared to the preterm population, where we have different scenario altogether. They are more prone to hypotension, sepsis, NEC, PDA, and nephrotoxic medications. PDA leading to the hypotension. So these are the different games altogether. There are the different, if you are talking about the etiology, the risk factors, maternal risk factors also play a very important role. Not a lot of studies are done on the finding the causes of maternal risk factors, but there was one study which was done to find out the causes of kidney injury in extremely low birth weight infants, less than 1,000 grams, in the Pediatric Nephrology Journal in 2011. So I just have mentioned here, which includes a variety of factors like maternal age, prenatal steroids, preeclampsia, hypertension, and other factors. The most important thing which remains is that we still have infection and other causes remains very high to find it out that it is important that maternal factors play an important role in the kidney development and further. Risk factors established in particular subset of population. So there was variety of studies. Once the definition of AKI was established, so there started a variety of studies, especially in the from 2006-07, where different age groups and populations were studied, and what were the risk factors associated in this population were quantified and qualified, qualitatively told. So a lot of studies were done again where we know that these babies are more prone to have AKI, and what factors we have got it, like low Apgar scores, exposure to nephrotoxic medications, maternal non-steroidal drugs intake, lower birth group, gestational age, and all those factors we can see, Apgar score. So they play a very important role. The most what I important liked it is that what is generally in an ICU. So pregnancy-induced hypertension.
Ankur, kindly unmute.
Yeah. So Bolat et al. Study in 2018, which says what are the general conditions in the NICU which leads to the baby for the, and very large study population was studied, found out various regions like pregnancy-induced hypertension, PPRM, and other factors, FGA, birth weight less than this, many interventions like intubation, UVC, ibuprofen therapy for PDA. So this all together combined that what are the various factors for a baby in the NICU to be there to lead to AKI. Again, a study, this is the group of population I have just told in order to quantify the incidence of AKI in different population. There we have found out the risk factors which lead to the, what are the risk factors in different age groups. Here we have found out the incidence of AKI in a different age group, and various studies have shown. And we see nearly the same what we have seen it earlier. So as I told you, when we are talking about the incidence and epidemiology of neonatal AKI, we cannot leave this AWAKEN study. And there were some findings which I will like to highlight from this AWAKEN study, which is very, very important. What they have found in their population is that there is a U-shaped distribution with the highest rates in the oldest, more than 36 weekers, and youngest, 22 weekers to less than 29 weekers neonates. So very interesting it is. that more than 36 weeker and 22 to 29 weeker neonates were found to have more AKI. There was no detailed description of why the babies from 30 weeker to 36 weeker were not having any much problem. And they told that this population are at more risk because they have low FGARs, they are more prone to HI, NEC, PDA. So the other population, other age group where it is more than 36 weeks, they are more prone to have HI and other problems. So they are more prone to have distribution, but there was no clear-cut answer for leaving the middle age group, middle gestation. So the incidence of AKI in the youngest population was around 48%. Similarly, the AKI in more than 36 weeks was 37%. And various factors for middle population, as I told you, were discussed, and none of them has been very convincing and has been very important to say that, yeah, this population will not be feeling any major problem. Because we were discussing perinatal asphyxia also from a long time, so just I wanted to quote a study from Indian population where first time they quantified the incidence of AKI in different stages of HI, and you can see very clearly the 25%, 88%, and 100%. So as the incidence of AKI, as the stages increases of HI, the babies more go into the chronic kidney disease rather than having an AKI. But at the same time, nearly the same age group was studied by Alora et al. I really don't know that what was the reason for them to find a very reduced numbers, though they have also found that the HI stage 3 ultimately has a highest incidence of AKI, but their incidence of AKI in stage 1 and stage 2 was very less. One of the important factor which I can consider here is that most of the babies may be getting cooling, because cooling is definitely a is a nephroprotective as well. So that has to be a reason, but I was not able to find it out. So drugs, we always talk about drugs. One of the most important things we know is that if our baby is having AKI, stop ampicillin, amikacin. So this is the most important things what we do, that remove potassium containing fluids and stop amikacin. So there are definitely drugs which has a different mechanism of action in order to cause the problem in the AKI, ultimately leading to AKI. So systemic and renal glomerular hemodynamic effects. So what they want to say is that the kidney dysfunction and kidney injury is the most important factor which has been found for the two mechanisms for ultimately leading into the AKI. So this is a very beautiful description that there are some agents which neither cause dysfunction nor injury. They can neither cause dysfunction of the glomeruli or tubule or injury, and still leads to AKI, like trimethoprim is one of the good examples of that. And then comes the dysfunction without injury. So there is a glomerular dysfunction which includes the drugs that impact kidney function through systemic hypotension or intraglomerular hemodynamic effects. So kidney dysfunction is caused, and there the drugs like angiotensin converting enzyme inhibitors or angiotensin converting enzyme inhibitors are one of the most important drugs in this age group, which has caused dysfunction without injury. Injury markers, injury without dysfunction, where the injury is one of the most important causes, is again lot many drugs that includes causes injury through the various mechanisms, including tubular cell injury triggered and toxins, tubular obstruction or an allergic reaction. And there are some drugs which causes both dysfunction and injury. The most common drug in dysfunction and injury is NSAIDs. So NSAIDs definitely causes both dysfunction and injury. And the drugs which causes injury without dysfunction is like ibuprofen, another class of drugs which just causes injury. They just affect the tubular epithelium rather than causing dysfunction of the glomeruli or the tubule. Again, the same things are discussed in details. So cyclovir is one of the most important drug, where we have found that it is also one of the important nephrotoxic agent, especially with low flow hypovolemia. So here also it causes more of kidney dysfunction. Angiotensin converting enzyme inhibitors, as I told you, it decreases. It is also kidney dysfunction is the mechanism of action. Aminoglycosides, toxic to the proximal tubule. So these drugs causes the injury. Tubular injury rather than dysfunction, and amphotericin B and non-steroidal anti-inflammatory drugs and radiocontrast agents are different groups, which are one of the most important causes for AKI, and has to be actually titrated if it is definitely unavoidable or has to be avoided. So progression to CKD, we have discussed so many factors, so many etiologies. So ultimately, what is the incidence of them to lead to CKD? So definitely there is a good going incidence, and these are some of the important factors which are ultimately lead to CKD, or these are the important population risk population which can ultimately lead to the CKD from AKI. So low birth weight, preterm birth, perinatal asphyxia, and congenital heart disease are important factors. So ultimately, we have reached to the evaluation of AKI. I want when we have AKI, the first and the foremost important thing is that to establish that we are having AKI. So that remains an important factor. So evaluation of AKI, where we have systemic approach. Systemic approach means first we have to go through our medical schools, and we have to follow first taking a history, then examination, and then ultimately the lab parameters and other things. So detailed history like gestational age, antenatal ultrasounds, maternal risk factors, birth having any problem, any maternoplacental insufficiency, postnatal events like we have taken any nephrotoxic medications, hypotension, and a complete history of the baby, or the baby had AKI or any major event during the delivery is one of the most important factor. When we talk about the physical examination, the one thing only one thing which we have to know, or we should know, is the volume status. And vital signs help in the establishment of volume status, because volume plays an important role. Most of the times we are having non-oliguric renal failure, the urine output is good, but the baby is landing into the AKI with higher creatinine values, and creatinine values we have to take into account, because that's what is defined as modified Kitgo classification. And ultimately, if we are having a volume status, if we know about the volume status, we can titrate the volume accordingly and do the needful. If it is pre-renal, we can give this, or if it is a renal or any tubular injury, then we can restrict the fluids. So thorough examination of volume is very, very important. And volume status is very well established by serum electrolytes, fluid balance, and importantly, body weight. Most of the units say that if the baby has AKI, please weigh the baby 2 times in a day to establish that whether we are more on fluids or we are giving appropriate amount of fluids, because other things are not the absolute. We cannot just absolutely tell them this, but body weight gives a good idea to us, and helps in assessing hypovolemia and hypervolemia. Serum electrolytes help us in assessing hypovolemia or hypervolemia because of the sodium levels, and fluid balance means total input-output chart will also help us in assessing the volume status. So serum electrolytes, again, I will talk to you in detail, because here it is a lot of things, like sometimes we have low sodium. We don't have to do anything much. It is because of the SIDH or other things. So we don't have to give the fluids. We just have to restrict the fluids in those scenarios. And sometimes the sodium is directly more, so definitely we have to replace the fluids. But this is not a very clear cut. Some here and there are there. And hypovolemia and hypervolemia we give. AKI can be oligouric or non-oligouric. Presence of oliguria and accompanying fluid overload are extremely poor prognostic factors, and that's why the weight checking and other factors are very important to not overload the kidneys, not overload the baby. When we talk about the urine output, defining reduced urine output in neonatal ICU was a big thing. And here I will go again a modification in the classification of AKI. And in the modification, the classification is AKI. So what happens is that acute kidney injury, this has ultimately lead to revising the definition of AKI in terms of urine output. So what we know is that defined as urine output less than 0.5 to 1 ml per kg per hour. Oliguria, if we are talking, we have to be very sure about the duration, because that's the most important factor. If we have 6 hours to 12 hours, still okay. If we are having oliguria for 24 hours and more than that, then definitely we are going in a bad shape. So oliguria duration is also very important to know. And Breeze et al. Recommended adopting higher urine output at more than less than 1.5 ml per kg values for the newborn than those in the P-rifle. So this is what I was talking about, that ultimately we are going through a lot of changes in the definition of AKI in the terms of urine output, because most of the kids go for non-oliguric renal failure, and if we take 0.5 or 1, we may be having AKI, but we will not be able to quantify. So it's very good to take less than 1.5 ml per kg per hour as a cutoff, especially in the premature babies and other babies where the urine loss is more, where they are diuresing. So it is a good thing. Kids have a greater body surface area, which is one of the most important reason. That's why they have high urine output. Oliguria can be present without AKI, especially in preterm infants. So this is another thing which we have to see. So when we come on lab parameters in AKI, so lab parameters again we will be serum creatinine. I just wanted to tell one more important thing. When we are talking about when we were talking about the serum biomarkers, so serum creatinine is taken as a gold standard or taken as a baseline thing, and all the biomarkers are compared with the serum creatinine values for that age, for that gestational age, for that day of life, for that gestational age, for with that biomarker, and it is very difficult to establish the efficacy of biomarkers in neonatal population because serum creatinine is having a maternal reflection, and then it is decreasing at a different value, it is increasing at a different value. So that's why the efficacy of biomarkers has also not been still established, but we have some of them. So when we talk about the lab parameters, so definitely serum creatinine plays an important role, and persistent of maternal system serum creatinine up to 3 days of life, and overall low glomerular filtration rate and maturational difference in the creatinine absorption at the level of proximal tubules. So in fact, because we don't have so much maturity of the kidney tubules, so we may be having high creatinine values, though we are not having as such AKI or very high AKI, or may not be having AKI. So these all things have to be taken into account. It is not so straightforward. Renal indices, I've taken this picture from AIMS protocol because none of the recent studies say so much about the renal indices, but they do definitely talk about the fractional excretion of sodium. And these values also differ rather than what has been described here also. So what they say is that if you are having a fractional excretion of sodium more than 6 or 7, then you, especially in the preterm population, then you think of it as intrinsic renal failure. And if you have renal failure index of more than 5 or 6, then you consider it has to be intrinsic renal failure, rather than these numbers where what it has been shown here, and these are the calculation how we can do it. Radiological assessment remains an important part and parcel of completing the workup for the diagnosis of AKI, and obstructive etiology has to be ruled out if we are not having any straightforward risk factors, if we are not having any cause for AKI, and obstructive etiology, if we rule out, it's very good. And routine ultrasound, there is one thing, this was another thing which I have taken, whether routine renal ultrasound for babies with single umbilical artery, what is evidence? So when we were there in our college days, so it was very, very clear that if there is a single umbilical artery, we have to go for the abdominal scan in order to see for the renal things, how is the renal parameters, how is the development of the kidney. But a lot of studies have been done, and they don't show any clear-cut association between the single umbilical artery and having any renal problems. It is not routinely administered in the current situation, and we don't have to do it actually. So radiology for the obstructive etiology, yeah, that is must. This is a very recent publication in 2017-18, which is in the Journal of Renal Injury Prevention. A beautiful article from the Indian people with they say that the most important key remains in the management of the AKI with non-dialytic management, means medical management. And if we have to go for the CERT or continuous renal replacement therapy or dialysis or whatever, then definitely we are going bad. We are having more chances of having CKD. We are having more chances of bad outcomes and other things. So the expertise in having management through medical management will be the key in all the cases of AKI. And if very well dealt, we will come out of just AKI. We don't have any further bad progression. So assessment of status and volume, again, it comes down to volume. So weight gain, loss. So as I told you, weight gain is a very important factor, and weight gain with oliguria is a very bad prognostic factor. So weight gain of anything more than 20 to 30 grams per day, if it is happening, it's not good. And we have to restrict it. We have to assess the baby again. Vital signs, we have to see for the baby like marker of hypovolemia, because if the baby is having tachycardia or poor perfusion and other things are there, then definitely the baby can have hypovolemia, and we have to replace the volume here. Serum sodium, as I told you, very sensitive marker for fluid status and is very important for management. Hyponatremia and hypernatremia is both what we get. If hyponatremia is there, we have to assess that whether it is a dilutional hyponatremia or we are having any other reason for hyponatremia. If hypernatremia, then definitely we have to think that we are less on fluids and we have to give the babies the fluids. So that's how it is. And combination of weight change, past few days, input output log, and change in the vital signs and the serum and urinary chemistry is used to determine the fluid status. So whatever we have talked till now in the evaluation, everything is being combined. If we definitely combine everything, we will get a good idea. We'll also get an idea whether we have fluid loss or we are having more of intrinsic renal failure or we are having more of pathology in the glomerulus of tubuli. So we will get a good idea. Assessment by echo. I will finish here the volume status, volume part completely. Echo as done by most of our esteemed faculties and our mentors. So I remember Venkatesh doing echos every time in Manipal Hospital. So echo remains an important factor in assessing that whether we are having less of fluid, more of fluid, whether we need to give boluses or we can just restrict it, and very useful modality to assess things. So when we have established that we have volume depletion or we have to supplement the baby with the fluid, what happens is that if we have a clear-cut thing that we have to supplement the baby with the fluid, then we give it. But most of the times, if we don't have a clear-cut idea also, most of the neonatologists or nephrologists end up giving one bolus at least to the babies so that ultimately they will have they have how they so that ultimately we can further restrict the IV fluid intake at that time. So the consensus remains whether crystalloids or colloids, what should be given. I will talk on this a little bit late. And albumin is very, very debatable. We don't colloids. I can finish colloids right now. Colloids, they don't say that a very much beneficial effect has been noted if you supplement colloids in the babies. But if you are having sepsis or you have to give the fluids to the baby, it's better to give the colloids at that point of time because it will take care of the other things as well and correct the other things as well. And ultimately, you are giving the fluid replacement also. So if it is required, you can give it, but not a very preferred choice, and especially not at all a preferred choice for the initial depletion if it is there to supplement it. And albumin is again a debatable. It's not very much recommendable. Ultimately, we after giving a fluid, we ultimately go ahead and do the diuretic challenge test. If we are still not getting a good urine output after whatever we have done on the fluid part, and most of the times we come out well, and a single dose of Lasix helps us in establishing a good urine output, and we are out of it. But by chance, if we are not there, we are not able to establish it, then we have to restrict the IV fluids. We have to calculate insensible water loss, and we have to calculate previous day urine output, and we have to give the fluid for that day, because then you can ultimately lead the baby to a volume overload, weight gain, and other things which we don't want, along with the oligouria, which we don't want. So insensible water loss, I just wanted to give an idea to the many people. So if it is less than 750, 100 to 150 is ml per kg per day is insensible water loss. 750 to 1000 grams, 60 to 70, 1000 to 1250 is 30 to 65. And for term babies, 40 to 50 ml per kg per day has been taken as insensible water loss. And this is a minimal fluid requirement plus yesterday's or previous day urine output, which will help us to extend. So I was telling about the crystalloids. So when we talk about the crystalloids are definitely the most preferred things where 0.9% saline we give or the NS bolus we give for the babies because if the baby is not diuresing or we are getting less urine output or if we are having a hypovolemia. So what happens is that a study has been done where they have assessed the difference between the balanced solution crystalloids and saline. And balanced solution crystalloids like ringer lactate and other thing. And they are saying that saline administration is also not so good. And we come across of various problems and adverse effects. And ultimately, it can be the balanced solutions like ringer lactates, which will be ultimately the way forward to give the fluid replacement therapy rather than using saline. Electrolyte imbalances, definitely we have to correct sodium correction. We have to do, most of us know that if we are having hyponatremia, we have to correct it. We don't have to correct it more than 0.5 milliequivalents per kg per hour. And there is a formula to correct it, and we can correct if they are having any symptomatic or we are having hyponatremia. But most of the times, a certain amount of hyponatremia do correct on its own as well if we restrict the fluid because of it, because in term baby with HI and other things. Potassium. So potassium remains again, potassium correction is common in the oligouric and anuric phase. And confirmation by potassium is one of the challenge we face in AKI, and hyperkalemia is one of the most important things. What we do, first of all, we, as soon as we get some idea that we are having AKI, we remove the potassium containing fluids. But first of all, it's very important to establish its diagnosis by venous sample rather than doing Hill prick, which we get in the gases, and it is not a reliable thing to say that yeah, definitely we are having hyperkalemia. Xylate associated with a lot of GI complications, and it is not the preferred way forward to be given. And all of the studies do recommend not to use xylates in lowering down the potassium. Salbutamol IV is also the great choice and do good effects. And salbutamol nebulizations are also tried, but we don't know that how much efficacy is there, and depend on the gestational age as well again, because in less premature babies, we don't have the receptors for the salbutamol to act. And then calcium gluconate infusion, sodium bicarbonate infusion, and insulin dextrose. So these are the some of the things. Calcium gluconate infusion to stabilize myocardium, sodium bicarbonate infusion. You have to be very, very precautious if you are giving soda bicarb infusion, because soda bicarb, in order to correct the metabolic acidosis associated with it, if you are giving, because if you are giving in the preterm babies, you can ultimately land up in IVH, and you have to be very careful about it. And insulin dextrose solution is a very well done thing which we do for most of the babies. Calcium and phosphorus also needs to be maintained. Hypocalcemia, hypomagnesemia, and hyperphosphatemia is one of the important factors which we have seen in the babies with AKI, and all these factors have to be managed. This is again the slide taken from the AIMS protocol, that at what different levels of potassium, what intervention you will like to do and how to manage it. So it is there. Once we have completed the volume, we have completed the management of how to take care of the volume and different things. So if we have taken care of the electrolytes, so what we have to take care is shock. So if we are taking care of volume in one way, we are taking care of the shock, but it always doesn't happen, because if we are having hypovolemic shocks, then it's okay. But if we are not having hypovolemic shock, we are having cardiogenic shocks, septic shocks, and other things, so then the ball game is different, and we have to use it differently. So if sepsis is there, then there is a distributive or cardiogenic shock. If there is patent ductus arteriosus, there is a diastolic runoff. So if it is so much, then we will have to go for medical and surgical closures. And this is from the same journal that what we have seen in 2017, the non-dialytic management, and they have the different mechanisms how to manage it. So necrotizing enterocolitis, systemic inflammatory response leading to distributive shock, intravenous fluids, vasopressors. When we are talking about hypotension, vasopressor remains an important thing, because we have already discussed volume. So vasopressor, dopamine in low dose has been, from ancient times, has been found to be very, very effective, and a lot of studies are there. But again, in preterm babies, we don't know how much is the efficacy of giving dopamine, and we are again stuck. Dobutamine is tried if we are not getting good response on dopamine, and many people use dobutamine after using low doses of dopamine and not getting beneficial effect. Epinephrine and norepinephrine are the choices in the cases if we are having, especially if we are having septic shocks and other things where the sepsis is there, in order to maintain the integrity of the vascular system and increase the urine output as well. Hydrocort again remains an important thing, where we have all the vasopressor are not working, and we have to establish the cause. But again, hydrocortisone, how much is to be used, and whether it is to be used or not is again debatable. And it is not that we are very confident or we are very happy to give it, or we should be definitely, steroids to be always avoided, but if it is required, then we may have to give it. Diuretics, once we are done with the vasopressor, diuretics. What is the incidence of diuretics? Ultimately, you are not urinating, so you want to give diuretics? No. Loop diuretics, furosemide has been studied a lot, and it has been told that it is better to avoid diuretics. And although in the cases of oliguria or anuria, if you are not getting anything, you have to give diuretic, especially loop diuretic like furosemide. But again, associated with a lot of adverse effects, and you have to be very, very cautious about it. But ultimately, large benefit doesn't come. There are some studies which have used bumetanide in extremely low birth infants. There is one study which has done that. This is the study from 2011, if I don't forget. Yeah, so 2011, which is pediatric critical care medicine, and they say that bumetanide is also works directly on the proximal tubules, and it is increases urine output. It is slightly better to work as compared to furosemide in extremely low birth weight, but there are one or two studies regarding that, and one systematic review also. So people do use this drug, but I have not seen being used in my experience. So preventing drug-associated AKI, again, if we are talking about the drug, ultimately we came to drug. We have studied the drugs in etiology, and now how to preventing drug-associated AKI. Like, so I do remember whenever we were there in a motherhood hospital, so Dr. Pratap sir used to always tell that what is drug stewardship. So drug stewardship ultimately leads to you to preventing of AKI, and very, very important, and it has to be done very wisely. Risk benefit of a particular drug, and has to be assessed. Dosing of the drugs has to be adjusted depending on what is the urine output, what is the GFR, and the formulas are there in different all the standard textbooks. And they say that the triple whammy of renin-angiotensin system inhibitors, diuretics, and non-steroidal anti-inflammatory drugs. These three drugs you are having the highest chance of having the AKI in the settings of AKI, or these drugs per se can ultimately lead you to AKI. So definitely combination of these three is difficult, and it's better to avoid all three together. Prevention of contrast-associated AKI. So what only a take-home message from here is that the current agents are quite safe, and they doesn't cause so much problem, provided the baseline creatinine values are okay. And if you are not having the baseline creatinine values any problematic, then most of the agents doesn't cause AKI, and they are quite safe. But baseline creatinine levels have to be established. Nutrition plays a pivotal role in the management of AKI. Protein intake 1 to 2 gram per kg per day. You have to make a balance of the protein, because if you give excessive amount of protein, then you will be producing excessive amount of urea. Ultimately, you are not urinating, then the urea keeps on increasing. But you cannot completely avoid it also. So a balance has to be maintained. Most of the babies who are sick, who are having AKI, or on TPN, or on IV fluids, so protein intake is mandatory, and we have to continue that. Carbohydrates, again, 4 to 6 mg per kg per minute of GIR will be good. Basal energy requirements of a newborn are 50 to 60. And if we talk about the growing preterm, we have to make sure that we are giving adequate energy to the baby. Growing preterm wants this. And caloric requirements of the TPN or baby who are not, we are not giving any feeds or anything, should be around 90 to 100 due to lack of fecal losses and diet-induced thermogenesis. This is a standalone thing where the efficacy of theophylline has been found out, that how is the efficacy of theophylline in the prevention of acute kidney injury. And they have found that theophylline and aminophylline has been studied, and they state that the theophylline do act. It has a mechanism which increases damages to the kidney. Renin angiotensin mechanism, it do act, and ultimately it is found beneficial. So some of the people do use theophylline. Is a recent 2012 that KidGo classification also say that a single dose of aminophylline for a asphyxiated newborn gives us a very good result, and ultimately may prevent the baby landing up in AKI as well. So severity of AKI leading to CKD is very, very important. So here you can see that we have non-nephrology based care providers, and as ultimately we reach stage 3 and other things, we have other problems. So we are having more of other issues. Ultimately, it is the nephrology based care providers, which are the proper nephrologists, because we may have ultimately landing up into the replacement therapies like dialysis or hemodialysis. So that's how it is severity. So we are coming to the last part of it, continuous renal replacement therapy. This is the last ditch effort to an early therapy directed at supporting critically ill patients by maintaining electrolyte homeostasis, allowing for provision of adequate nutrition, and preventing reducing hypervolemia. If we have done it, we mostly doesn't land up here, but ultimately if you land up here, this is the last thing any neonatologist want in the unit. And if ultimately it happens, you have to manage it, you have to take care of the multidisciplinary approach, and you have to do whatever is required. So this is one of the indications of RRT, like fluid overload. The two main mechanisms how we do it, renal replacement therapy, is peritoneal dialysis and hemodialysis, all of us know. And peritoneal dialysis can be easily done at bedside, and that's why it is very famous in the pediatric in the neonatal age age group rather than going for hemodialysis, because hemodialysis efficacy and everything is very less established in weight less than 5 kg, and how to do it, equipment problem and other things are there, and availability of equipment is a problem. So peritoneal dialysis is very routinely done in most of the cases. So if we see there, that will be the first thing for us to do it. And hyperkalemia, hyperammonemia, high blood urea nitrogen. So peritoneal dialysis but they give fair result. And if you are going for hemodialysis, then definitely the results are wonderful. So providing RRT, it should be a combined approach. And as Dr. Prashanth was talking too much about the parental counseling and involvement of parents. So providing RRT is a shared decision where the patient, the multidisciplinary approach, and parents have to be involved, and they have to take a decision that we have ultimately going for the RRT. And this is a good diagram when to start and when to stop it. So here it says that the medical evaluation for RRT initiation, there should be medical reasons, then we have shared decision. And if everything is yes, then we start optimal RRT, depending on peritoneal or non-hemodialysis, and we have to keep assessing it every time. And if we are better, definitely we have to stop it as soon as possible. Or if we are not able to stop it, if we are going ahead, then ultimately we are going towards this more bad prognosis. And if the things are not improving, ultimately you can stop RRT also. So that's again a parental consensus. So peritoneal dialysis, several studies describe successful peritoneal dialysis by several different techniques and critically ill units. So if you are talking about the extremely low birth weights baby, very small babies, it is very difficult because we have a lot of other issues. The maturity is not there. The peritoneum acts as a filter, ultrafiltration mechanism where, and that's why how we take out all the waste products from the body. So here it is very difficult to go ahead for the peritoneal dialysis and the invasive procedure for babies less than 830 grams, or in fact less than 1000 grams for that sake. So duration of dysfunction. So as I told you in that slide, so if we return back to normal in 8 to 10 days, we are good to go. And if it is taking more time, then definitely we are not doing well on so much. So follow-up of AKI, it is now very well established in the recent studies that if we are having an AKI, further the baby can land up in CKD, or the baby can have any other problems. So some of the studies say that NIDDK consensus is there that do follow up these babies at 3 months. Again, once you have discharged this baby, and see for the parameters, and if everything is okay, it's good. If it is not, then you may have to sensitize the patient that your baby is leading towards CKD. Because in first stage or second year, babies do develop CKD if we are having the AKI in the initial neonatal age group. So a lot of controversy still exists. I have tried to give us a clear-cut idea, because we should not be in the controversy, or we should not be in confusion when we are treating the baby. So whatever till now is available, we have to be very clear about it. But this is KDIGO Executive Council's conclusions, which came recently in 2020 only, I think in the June, where they have addressed controversies in acute kidney injury, conclusions from a kidney disease, improving clinical outcomes. So they have different consensus. The most important thing will be the key topics for future research, like evaluation of AKI in risk models, identification of clinical endpoints, role of real-time or kinetic GFR, impact of body composition on AKI criteria, and different things, determination of optimal indicators, availability of biomarkers. So we still have to answer these questions in order to be best at the management of AKI, which is not very less common. It is quite common in the risk group population. Takeaway message. Although much of the 2012 KDIGO AKI guidelines remain state of the art, advances over the past decade have improved our understanding of best practices. The neonatal kidney collaboration, it was recently formed in 2020 in NIDDK and AKI conference, where in the initial part of 2020, where it is an international multi-institutional and multidisciplinary group which has to answer many questions which are still unanswered by the help of the various studies and recruiting lot of population. So thank you. Thanks for patiently listening, and I hope I was able to do a bit of my job. And please ban Chinese apps as we have done by removing the Zoom. Thank you. Thanks a lot.
Thank you, Dr. Ankur. Wonderful presentation, and definitely acute renal management, acute kidney injury should be elaborated in detail. Thank you very much for wonderful presentation and good coverage. quickly we'll move on to the video part. After that, we will start the session. I have 3 questions based on counseling only. Can you stop sharing, Dr. Ankur?
Yes, sir. Yes, sir. Yes, sir.
How to counsel a baby with antenatal hydronephrosis? This is for Prashant. Based on their trimester, how frequent to do the when pediatric surgeon, if antenatal hydronephrosis is present, when to do screening for issues and prenatal testing. I think all these things will be answered with your video. So I request Dr. Prashant to quickly play the video. And I request you to fast forward certain part if it is not important in the video.
Sure,
Dr. Prashant, are you
sure,
there?
sure, sir. Yes, sir.
Yeah, because there are a lot of questions around
Yeah.
24, 25 questions we have got now. So we'll quickly address all.
Sure, sir. So can you see the slide, sir?
No. We're not seeing the slide.
No, not the slide. So the screen, can you see? It says Pediatric Management of Fetal Urological Diseases 2012.
No.
Just a second.
Can you stop? Yeah, now I.
Sure.
Yeah, now. Yes.
Yeah. So this is the video I would suggest for all fellows and probably the practicing people to look at it. So this is called CEVL. It's called Computer Enhanced Visual Learning Module. I'm not going to play the introduction part. So this is from Dr. Antonio and Dr. Max. And this is a US-based platform, and it's a wonderful thing for. So the problem is we need to log in, which I've not done, but I got a link from the Clinics of Perinatology 2014, a topic on hydronephrosis. All right. So this is how it is.
We organize our consultation according to the checklist. I have provided you.
Could you hear it, sir?
Yeah, but it's very lot of disturbances there. Could you please explain? Otherwise, if there, just play the video. If it's too much disturbances there, you only explain the counseling part. That should be fine.
Okay.
Your own copy. Understanding the diagnosis, coordinating care.
It's not very clear.
Let's
not
start.
clear.
Yeah, you can explain the video, the
So
counseling part.
Saying basically, so what are the things which we need to see while we counsel? So they talk about just a second. So as I said, so we need to have a ready reckoner here, and for prenatal as well as postnatal, and we need to be telling them the facts about what you mean by hydronephrosis and when do we define it as oligohydramnios and polyhydramnios. So going to the video clip. So this video clip basically plays. This one is actually a mobile app which actually is given by the CVL. So if you can see here, so the first part is understanding the diagnosis, so which will be taught by the video. The second thing, to look at the prognosis based on what algorithms which we just discussed, and also the coordination of care from different specialists, that also which we discussed. So let us see this small video. So this video also helps us to understand the etiology of hydronephrosis. And I thought it's actually very beautiful when we look at it. So if you can see this, so this is the 3D picture of fetal kidneys. You can see the ureter, you can see the pelvis there, and you can see the ureters and the bladder down here. We know that the urine passes through the ureter through peristalsis. And we also know that the amniotic fluid is basically formed from fetal urine. So kidney produces urine, it passes through the ureter, the bladder fills up, and the bladder passes the urine into the amniotic fluid. So that's why we have the amniotic fluid which is cycling inside. All right. So when we look at the ultrasound, so we need to know also sometimes parents also will need to know what does those figures represent. So this will show an overlap of your ultrasound picture along with the kidney. Here what you are seeing is the kidney. You are actually seeing the renal pelvis, and you are seeing the calyces, right? And here you are actually, the next highlights would be the medulla and the cortex. the red part is your medulla and the cortex. So as it grows, so you can see the callus is beautifully forming here. The pelvis actually decreasing, and you see that there could be some obstruction when the pelvis is enlarging and the ureter probably lags in the development. So this actually is represented by a small kink there. So sometimes it can, so when you talk about uretropelvic obstruction, so this is where it happens. So we talked about SCRP, so that is sonologically evident renal pelvis. So how do we consult a parent with the ultrasound report is what this slide says. So usually we actually get these kind of images from a radiologist or maternal fetal units. So this is how they are actually orienting for a better understanding. If you can see here, they have oriented to the newborn. So this is the back, and you can see this is the kidney. So this is how it looks in a sagittal plane. So this is your kidney. This is how they have measured it, and you can see the pelvis, and it's actually draining into the urinary bladder. So as there is obstruction in the passage of urine, so it becomes sonologically evident. The pelvis or the ureter becomes sonologically evident if there is any obstruction. So what are the reasons of this evidence? So it could be normal, where we actually discussed it, or it could be a top tight obstruction. So you can actually see that. So there could be an obstruction between the pelvis and the ureter, or the lower part of ureter which is passing into the urinary bladder could be kinked. So we all know about this. So this probably will help the parents understand about, okay, what could be the reason of hydronephrosis, and we are insisting that it could be normal also. So as they are actually reiterating, it could be normal, it could be blockade, or it could be lower ureter which is actually the culprit. So after this, moving on to the next one. So how do we differentiate it? So they are actually looking at, so there could be an obstruction here, or there could be obstruction below the bladder. So it could be distended, and once the urine bladder contracts, there could be a reflex. So this is the pathology of your UV reflex. So you can see there is some obstruction in the pelviureteric junction here, because there is a little bit of kink. So that's why the renal parenchyma is the pelvis has expanded. So, and after overwhelming forces, the urine trickles down into the ureter. So these are the two probably causes. These are the causes of hydronephrosis. So looking at the other thing, so this is another example. So we keep seeing this kind of images. So this one is a 28 weeks of gestational age. We can see both kidneys here with actually dilated pelvis. The pink represents the renal cortex, the yellow represents the pelvis. So this probably is what we see in our reports. So we actually get reports in this. So when we look at so it could be transverse section. So if you can see here, the transverse section here. So these are the different cross sections you would probably look at the film, and this is what I was discussing. So once we know the renal pelvis, looking at the gestational age, we will mark it in this particular graph, and probably tell them how much percentage will the baby be normal postnatally. So here, for example, 25 weeker, so they're actually showing 13 millimeter. The percentage of normal outcome would be 60%. Percentage of uropathy will be 40%. So that's just this one. So this is showing fetal bladder sagittal length. So this actually acts as a marker of how much the bladder has got dilated. And you have a nomogram for this also, which actually says where we can actually mark. and see whether it is a dilated bladder, whether it's a cyst, or it is normal. So this is a representational picture of micturating cystourethrogram, which is corresponding to the ultrasound which showed there was some urinary bladder dilatation. Okay, if you can see this, so after it is getting filled, there is backflow into the renal pelvis. You can see the dilated ureter. There's a lot of kinks, and also the renal pelvis which has actually dilated. So this is about it. So once it is done, so what are we going to do? So once we have interpreted the records, so then we have to give prognosis to the parents. So the first part, the topmost part is done. Second thing is prognosis, and the third part will be the coordination. So just two quick case examples here. You can see. So we have 4 steps basically in this. If you can see here, so it actually gives a gives an example. This is a typical ultrasound report what we get. So they actually mention the gestational age, and they mention the amniotic fluid index, and probably mention the anterior posterior diameter. So the step 1 is to collect these details, and we also need to look at other sonological evidence of problems. And step 2 is to look at our graph, so which I mentioned, and plot it in the graph to see where it falls on this current gestational age. So this particular thing has been plotted onto this orange color graph, so which actually says 70% normal outcomes and 30% the baby might have some uropathy. So this is how it is. So first we saw the gestational age, corresponding pelvic diameter, then plotted on the graph to tell the parents that, okay, this is what we are expecting. So just another case example. So the same thing. So we are looking at the gestational age. We are looking at the AP diameter of the renal pelvis. So plotting it in the, so the highlighted ones are the ones which you really need to look at. So this is a 34-week or 3-day baby. Right renal pelvis is 14 millimeter, and the polar length of the right kidney is 5.8. So we have plotted it in the green thing here in the left corner, right corner here, probably saying 60% of the time it could be normal, and probably 40% there could be abnormal. So as you see, so this is dependent on the gestational age. So for the same value, different gestational age gives you different prognosis. Okay, so this is how you probably go about counseling the parents antenatally for antenatal hydronephrosis. So coming to the other questions of the when do we look for surgical consultation. So this is the slide I would want you to look at. So when there is moderate to severe hydronephrosis, and so if there is evidence of lower urinary tract obstruction, so we definitely need to give surgical reference. So that means that there is bladder outlet obstruction, most commonly, which happens, the typical example is a boy baby who is having a post-urethral valve, definitely a surgical reference here. So when you have your diuretic renal scan which is showing obstruction, surgery probably is indicated. Now, when to involve surgeons? So we need to involve surgeons antenatally itself. And second thing is probably once the baby is born, so we need to be in track with them to see which way this baby is going. And as I said, so it could be based on the institutional protocol about to agree upon what do you mean by mild in your unit, moderate to severe in your unit, etc. based on the evidence. So this is how we would include the pediatric surgeons in this. Hello.
Yeah. So there was one more question. When to advise for termination of pregnancy with antenatal hydronephrosis?
Can you hear me?
Hello, Prashant. Can you hear me? Yeah. The next question is when to advise for termination of pregnancy.
Sorry, sir. I actually didn't get your question, sir. Could you please repeat, sir?
When to advise for termination of pregnancy with antenatal hydronephrosis?
Okay. So this is again a controversial thing, as I would say. So as I mentioned in one of the slides, just quickly go to the slide, please. Okay. So obviously the termination probably would, I mean, we are thinking of termination probably only in the second trimester. So when we say bilateral uh, hydronephrosis and we are suspecting lateral outlet obstruction, and with that we are having oligohydramnias, which are with having unfavorable outcomes. So unfavorable outcomes, when I say, it is associated with uh, chromosomal or structural abnormalities. So that probably that's when probably we need to look at termination. Again, as I said, it would depend on the situation or the unit which you're working.
Okay. There is one more question. How early can we diagnose antenatal hydronephrosis?
So how early? So that's a good question. So um, probably if you can see the slides graphs here. So the earlier hydronephrosis probably can be picked up as early as 20 to 24. So probably a proper fetal anomaly scan should be able to pick up some of the other problems in the pelvis, because we know that the urine formation starts at 8 weeks itself. So probably 18 to 20 weeks is probably the earliest time where we can start looking at this.
Yeah. With your permission, I would like to add one more thing.
Sure, sir.
Because yesterday I happened to do an anomaly scan for my wife. So I was asking all this question. So there she showed me an evidence that as early as even 12 to 13 weeks of gestation, you'll be able to identify antenatal hydronephrosis. So you're showing some article. That's why I would like to add that. Anyway,
Sure.
we have one more question. When to suggest for circumcision?
Circumcision. So the chances of UTI has been shown to increase in babies, male babies with antenatal hydronephrosis, and there are evidence. So I actually happened to show that meta-analysis also in 2007, the systemic review, which actually said that the chances of UTI probably will decrease if the baby is circumcised. So now I don't know when exactly you advise for circumcision. So but there is evidence that uncircumcised boys with antenatal hydronephrosis are predisposed to UTIs, but I don't know when to advise for it. I would say as early as possible. But our Indian Society of Pediatric Nephrology doesn't mention about this circumcision. So the
How
evidence
frequent?
is from the West.
Yeah. We have one more question. How frequently to do follow-up with antenatal hydronephrosis post-delivery?
Post delivery, so as I said, so let's go to our, I think it's a lot of overlap. So let's see. So as I said, the post delivery we need to do as a standard after 48 hours, that is 3 to 7 days, at least definitely before discharge. So two conditions where you would want to do very early ultrasound, probably less than 24 hours, is when you are suspecting bladder outlet obstruction. So, or a unilateral kidney with some hydronephrosis, you definitely need to do in less than 24 hours. And the repeat ultrasound will be done only at 1 month. So this flow diagram shows it clearly that so we need to do it after 48 hours and then repeat it at 1 month.
If antenatal hydronephrosis is present, when to do screening for genetic and prenatal testing?
Yeah.
On what basis?
Okay. Again, this again I happen to show in one of the slides. So when we are looking at this hydronephrosis, so we are not looking at only the excretory part of it. So as I already said, so we also should be looking at the additional features in ultrasound. So looking at systemic abnormalities and soft signs. So when any of these are present, so probably we would go ahead and look for other abnormalities also.
So is it necessary to screen all newborn babies for renal hydronephrosis? This is the last question.
Yeah, I would say yes. Because purely, if you look at the incidence, as I said, so incidence can go up to 6%. In a sense, out of 100 pregnant mothers, you can have 6 pregnant mothers having fetal hydronephrosis. As I said, so fetal hydronephrosis, around 90% of them could be normal. It's just a transition, so no need to worry. But the thing is, since we don't know exactly the cutoff, so which turns out to be a acute or which turns out to be a transient, it's very important for us to know. I would suggest every fetus has to be screened for this.
Okay, and I think Dr. T.P. Maya sir wanted to ask a question. I request Maya sir to unmute yourself, sir, and ask a question, sir. Maya sir, you can unmute yourself, sir. Yeah. So I think. Hello, sir.
Hello.
Yes, sir. Yes,
It's a very
sir.
nice, very nice presentation and quite informative, both of you. I just want to ask question to Prashant number 2. That is the, IAP recommendation. That's a consensus statement,
Right,
and
sir.
your recommendation. Any difference?
Yes, sir. So basically, it both are actually working on the same principle. So the recommendation what I have put up, so with the side, these two recommendations antenatally, as well as the postnatal approach, is from clinics in perinatology. But actually, when you look at the ISTN guidelines from the Indian pediatrics, so most of it actually correlates.
Thank you.
Yeah. So, Dr. Ankur?
Yes,
we
sir.
have around 11.
Okay, sir.
First question, what they have asked: which definition to follow for AKI? Whether it is P-rifle.
So I have told it very clearly in. I have told it very clearly in my take-home message that 2014 published in Critical Care, the KDIGO definition stands quite good, and you can take only the serum creatinine values as an important marker, or you can be using serum creatinine along with the urine output as a important marker for the defining AKI. But the modified KDIGO definition stands good, which is 2014, worked out in 2012.
Yeah, so I just want to add one thing, so with your permission. So my friend Dr. Hamsa, so who was actually doing the DM with me in pediatric nephrology, had also had a similar question in her mind, and her thesis was that which got published in International Journal of Maternal Fetal Medicine and Neonatal. So in March, I guess. So where she actually compared this modified KDIGO versus rifle criteria to look at which is better. So the same questions which was answered. So she was able to pick up more babies with AKI, neonatal AKI with neonatal modified KDIGO than rifle. So definitely it is KDIGO.
How can we predict the future outcome with the initial definition and assessment?
So, the outcome, as I told you, if we have many factors which will ultimately lead to the outcome, and the most important thing is that how fast the recovery happens, the days, and how, if the baby is not improving, which stage of AKI we are having. Either we are having stage 3 AKI, and third thing will be that if we are having a prolonged oliguria, increase in the weight, and we are on the renal replacement therapy, definitely we are having a bad outcome, and it will be ultimately landing up in CKD, and those babies will have bad future outcomes as well in the terms of CKD for their future.
Yeah. What are the red flag signs for a neonatologist for initiation of management of AKI? For a practicing neonatologist, when do they have to get alerted that he is moving into that? What are the red flag signs?
Very good question. Most important, I will say, whether to go take care of the red flag signs, it is better to take care of the history. My whole talk was risk stratification. We have to talk on risk stratification. We have to identify. We are not thinking of every baby in the neonatal unit going into the AKI. We have it's a risk stratification. If we will do, if we are thinking it's a preterm baby, if it is a baby with having a IUGR component, or if the baby is having low Apgar scores at the time of birth, if the baby has HIE, or if the baby is having hypotension. So, or there is no single factor which will ultimately, I can say, that is a red flag sign, but we have have to riskily stratify. And if we are dealing with a high level of neonatal care, we have to take care of the kidneys and we have to take care of the AKI, and we have to do the serial measurements of the creatinine values. The baseline creatinine values in all the babies in the NICU should be established. Though we can do it at 3 to 4 days, we can have metal reflection till 3 days, but it will be good to do it so that we can later ascertain that how we are going ahead with creatinine and AKI.
There's one more question. Is the renal dose for all drugs necessary during AKI?
So again, very good question. If it is a AKI, and it is definitely what the latest studies have said, that it is better to do the adjustment, and it better to avoid the drugs which can cause AKI, because it's an add-on factor. It's just that not that AKI can be the result of any other factor, and if we are doing this, it can be an add-on factor which will ultimately have a bad prognosis. So it is better to avoid it if we can avoid it. If we cannot avoid it, it's better to do the adjustment. Definitely, if we are having oliguria and other things, because then the outcome will be good.
Okay, there's one more question. What to do when baby has severe hyponatremia along with acute kidney injury? How to calculate fluid?
So again, a very good question. So the most important thing, if we are having severe hyponatremia, we have to correct it. Otherwise, we will have different clinical features. So the calculation stands good. 0.6 to 0.8 into the conversion factor into what is the value, what is the desired value you want, as like 135 minus whatever you are having, and into the body weight. So that gives us a clear idea that whatever depletion amount we are having, plus we have to provide the additional sodium daily requirement, and we have to calculate it and give it. And we have to also take care that we don't exceed the correction values of 12 in 24 hours. And definitely, otherwise we will have other clinical problems. If we are having, we have to correct it. We have to correct it, and we have to establish the cause of hyponatremia and do accordingly. If we are thinking that it is because of severe, if it is because of necrotizing enterocolitis, or if it is because of HI, then you restrict the fluids and do accordingly.
How sensitive is urine output in AKI in non-oliguric renal failure?
So that's what I've told. Still, that is a debatable question. The consensus of the KDIGO Executive Council is that only that find out the exact urine output that you can say that the baby is having the oliguric or renal failure. But what I have told is that the latest classifications take it any urine output less than 1.5 ml per kg per hour in neonatal population as oliguria. As oliguria.
What is the role of dopamine in acute kidney injury? The latest evidence.
Role of dopamine in
Acute kidney injury.
So
we have
it is one of the most studied drug, and it is one of the most used drug in the low concentrations in order to improve the renal blood flow. So it acts by various receptors, D1, D2, and various receptors. So ultimately, the overall best evidence whatever we have got is that the dopamine is still advisable in the cases of hypovolemia or shock. And if we are not getting benefit on that, then the other things have to be tried. But dopamine stands, recent evidence also says that it stands good at renal doses, at low doses, not at high.
Okay. Which one is common, oliguric or non-oliguric, and which has got the good prognosis?
It doesn't happen like that. I've not seen any article or anything like that. But what I can say is that it again depends on the cause. If we are having more of premature baby or prematurity, then we see more of non-oliguric renal failure, because the tubules are not so well developed and there will be the water loss happening. So that's why. But ultimately, if it is a premature baby, also will ultimately land up in oliguric renal failure if the AKI is progressing, if it is not getting corrected, or ultimately if we are leading into the CKD. So definitely oliguria with the weight gain is considered as the worst prognostic factors. And ultimately, if the baby is having non-oliguric renal failure, because it is difficult to define AKI, but if it is progressing, ultimately will lead to oliguria, and oliguria will have bad prognosis.
What is the ideal time post-delivery which reflects serum creatine level of a baby?
So the most of the studies says that up to 3 days is what we get as the mean age. They have taken as 3 days for the creatinine values to be maternal reflection. But again, a lot of differences there. If I talk about the creatinine, so creatinine gets extra secreted in premature babies because of the immaturity of the tubules, and again it will be very different in the different age groups, muscle mass, and all those factors are there for ultimately creatinine to get excreted. But 3 days is a normal thing, which is says that maternal factor, it is reflecting maternal values.
Is there any surrogate marker for GFR in AKI?
Surrogate marker of GFR. That's what we have. I think the candidate is asking for biomarkers. So if we are asking for biomarkers, we are working on that, and I have discussed some of the biomarkers. What they say, cystatin C stands very good along with the GFR in the early diagnosis of AKI and the prognosticating also, and it is one of the good biomarker. But the other biomarkers also stands good, but we don't have the accepted data.
Okay. What is the type of fluid recommended in AKI?
So fluid recommended any, as I told you, you have to take care of TPN. You cannot divide the baby of TPN if you are not giving anything, because if the baby is on your IV fluids and the baby is sick, so TPN remains the standard of care with protein, basic protein requirement. And the IV fluid, which we routinely use in the babies in our unit, we will be using it, or we will be making separate units with potassium-free fluid will be the go forward, and we can make it separately. Most of our units do electrolytes separately and fluid separately for the babies, so that's how we can do it. But we have to provide adequate GR, we have to provide adequate TPN, and we have to provide adequate electrolytes like sodium and other things.
What do you infer if you incidentally find serum creatinine of 6 in 11-day-old unit with maternal creat of 0.3 and no asphyxia or sepsis or shock?
So this will be a case of mostly hypovolemia, which may ultimately lead up to CKD. So creatinine values of 6 is quite bad, and definitely requires, but it will be an algorithmic approach. We have seen some of the babies with a high creatinine, very high urea levels, to come back without doing any straightforward interventional measurements. We have to do algorithmic approach, be on the baby, and see how it happens. If just the fluid depletion is one of the most important cause, the baby has lost weight and other things, so we have to go from there.
You had mentioned not to use pre-renal, renal, and post-renal, but you mentioned renal failure index, which is used to differentiate pre-renal and renal. Please
so that's what I'm saying. According to the recent what data, according to the consensus, we should not use it, because the pathology is not straightforward in our neonatal population. It's not that we are having a hypovolemia, we are having straightforward tubular kidney diseases and post-renal causes. So mostly the post-renal causes in the neonatal population are 2 to 3%. So intrinsic and pre-renal, I have told not to differentiate. And but I've told you about the renal failure index and FENA, because this stands quite good in helping us to how to go forward, how to take care of the volume, how to take care of the fluids. So that's why if we are stuck, we can do these measurements, which will guide us definitely, but their values are different. Their values in premature babies are different, so we have to assess it properly. As I told you, what is mentioned in AIMS protocol also, it is different. FENA more than 6 will be considered as abnormal or intrinsic renal failure in cases of premature babies. So we have to interpret the results differently here. That's why it is better not to classify it. But ultimately, it's a very hand-in-hand process. You cannot completely not do anything, and you can do one thing. You have to do everything.
Yeah. So there is one more question. Both of you can answer. Can we say chronic kidney disease for antenatally diagnosed hydronephrosis?
Dr. Prashanth.
Yeah. I think it's a tough question to answer. So because when you look at the definition of CKD, so they talk about less creatinine for over 3 months. So just by definitions, I don't think we actually can quantify the creatinine in utero. So I don't think the definitions will probably will not hold good. So although if you don't, I mean, although if in severe cases, so where the renal function is compromised, even not branding the baby as CKD, we should be looking at treating the baby like any CKD or a kidney injury baby. So, but I don't know if we can define it as CKD, because this CKD definition wants a creatinine clearance, and it also is based on 3 months. So, which we don't know. We don't know the onset here. We don't know the duration in antenatal hydronephrosis. So, there is no definition as such. Ankur, I'm going to take.
I think I ran out of all the question.
Yes.
If any of the audience has any questions, they can unmute and ask. Meanwhile, getting a lot of good feedback. Maya sir has specifically sent a message that excellent presentation. The both of you, it is appreciated personally. He has sent a message and he has told me to send the regards to both of you.
Thank you, sir. Thanks. Thanks.
Would you like to ask any question?
I actually saw one of the questions from Dr. Chandra, I feel. So, doctor had asked about, so what is the role of, other than postnatal ultrasound, so what is the role of looking at creatinine electrolytes postnatally? So that's actually is a very relevant question and a good question. So I actually kind of skipped it when I was talking about that. Yes, we definitely need to look at the electrolytes, creatinine, and how the kidney is functioning postnatally, more so in cases where we are strongly suspecting CACUT or bladder outlet obstruction. So we definitely need to look at serum electrolytes. We need to look at creatinine, urea. We're going to look at, so we probably, first time when we catheterize or when we take out the urine, you need to be sending for urine analysis for all the indices which Dr. Ankur said. So yes, definitely yes, when you're when our diagnosis is going towards CACUT. And I also saw one of the other questions, I think, from Dr. Chandra. So, what about the parameters? I spoke about the parameters on fetal urine, which actually says that the kidney function is okay. So, what about amniotic fluid? So, yes, studies have looked at any indices in the amniotic fluid which actually correlates with the renal function and later prognosis. So, the most studies, so probably 2 to 3 studies which have looked at beta microglobulin in the amniotic fluid. However, it's not been correlated well, so that's why it is not included in that the criteria for favorable prognosis based on the biomarkers. Yeah, so these are the questions I saw while I was just talking. Yes.
I think we have reached now almost 8 o'clock. Time to end the session. Thank you once again for your wonderful session. Kotreshi sir, are you
One
around?
question.
Yeah, Naresh sir. Yeah. पूछिए sir. पूछिए sir. Hello. Hello sir.
Yes, sir. Can we diagnose fungus ball with ultrasound? And it should be managed by conservatively or surgically?
सर अल्ट्रासाउंड में डायग्नोज कर सकते हैं सर, फंगल बॉल, किडनी में बॉल, सब जगह में, नो प्रॉब्लम. बट उसका टॉपिक अलग है सर, वो आ रहा है, अलग से वर्कशॉप आ रहा है सर नेक्स्ट मंथ. 10 classes we are having on ultrasound. हाँ सर.
That concentrated feeds can lead to renal problem.
Concentrated feeds, आप formula feeds के बारे में बात कर रहे हैं सर?
If the baby is provided with too much thick feeds to the baby.
Sir, I will like to take it like if we say about the thick feeds, the most important thing stays about the overall water, whatever the fluid requirement is there, whether you are giving it or not. Rather than thick feeds, if you are giving, it doesn't cause any problem to the term babies. Only thing is that in the preterm babies, it may be the cause of NEC or other things. But appropriate amount of fluid is definitely required for kidney to function well. If we are giving thick feeds and the quantity of water is less, then we may see the changes of pre-renal AKI or hypovolemic AKI.
Sir, then hepatic injuries can lead to renal injury or renal injuries can lead to hepatic injury? Is there is correlation between them?
Yes, sir. There is a correlation, and it is called as hepatorenal syndrome. See, sir, this all things are very well studied in pediatric age group, where we say something called as hepatorenal syndrome. So they are interrelated, and they do affect each other. And a lot of evidence has been found, and there is a syndrome associated with it. But if we talk about neonatal population, no much studies has been done, no much relation has been established. I didn't find any relation per se, sir, in neonatal age group in the babies with AKI having liver involvement as well.
Should we routinely investigate the renal function in cases of congenital anomalies of the heart?
No, sir. See, sir, what I would like to say, if you are having congenital anomaly of anything, if you are having any congenital malformations or anything, then definitely you will have to see for everything. But if or you will have to do also karyotyping. But congenital problems of the heart have leading to kidney. There can be association if there is associated syndrome associated with it, but not routinely, sir. We don't do it routinely for the babies having cardiac problems, renal assessment. No, until unless the baby was sick or in the ICU.
Does these renal injuries have a genetic basis?
So renal injuries, genetic basis is definitely there, sir. Like if we talk about any specialized any problems, like congenital problems or any obstruction or malformations, then definitely they have genetic association with it. But here we were talking about AKI. So AKI doesn't have genetic association per se, but only genetic association is that the nephrogenesis. Nephrogenesis is again genetically determined. So how good will be nephrogenesis? Less chances of AKI.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you. Thank you for wonderful presentation and patient listening and clearing all the doubts. Thank you. Have a great evening. Bye.
Thank you, sir. Thank you.
Yeah.
Thank you so much.
Prashant. Hello, Prashant. Hello.
Yes, sir. Yes, sir.